Welcome, everybody. We're going to get started here in just a few minutes while you all populate. Give us a moment to take care of some housekeeping and get ourselves streaming over on Facebook. Welcome to this edition of the Bighearted Warrior Tour. This is my first of the year. I missed the first one. Stacy took the helm on that. So tonight we are with our friends at the Cleveland Clinic and some of our oldest friends, and I don't mean that chronologically, but we've been working with the Cleveland Clinic since probably early 1997, maybe late 1996, when we first began our work here at the HCMA. So we're excited to have this whole team here. Let's just get over to Facebook and let those Facebook people who forgot to sign up for the webinar get here in time. We've got a large crowd coming in tonight. So we are looking forward to getting everything going. And you know that I'm waiting for something to go live when I do the do. Okay, so we've got a bunch of people joining. Oh, and this is why we are moving to a different format because it's not allowing me to go live on Facebook right now. Give me a second. I'll try one more time. She is not behaving tonight. Stick with us for a few more minutes and we will be getting this party started. So there's a great article today about a woman who got a heart transplant 31 years ago and her underlying diagnosis was hypertrophic cardiomyopathy. And she made it 31 years plus. So I have a new milestone. Okay, so it timed out again. One more try. We are not getting over there, so we may not be able to stream this evening. I don't know what's going on. One more attempt. And we'll try YouTube as well. So this is why we've been moving to a different platform because we've been having a lot of technical issues. Yeah, we're not able to stream on either platform right now. All right, so all you lucky people who signed up for the webinar, all 220 of you, it's just you and us tonight. We're not going to be doing that social media thing. So Julie, Stacy, if you could throw in a link into Facebook, into the private group, as well as the page, and just put the link for people to join us live. That would be really helpful. Okay. So I've tried 4 times. It's not working. And this is why we will be moving to Vimeo very soon. All right, ladies and gentlemen, we are going to begin tonight's adventure with Cleveland Clinic. Let me get my slides going here. And let me just tell you a little bit about what's going to be going on tonight. So welcome to this edition. It is 6:31 p.m. on February 18th, 2025. It is Heart Month. We are just about a week away from HCM Awareness Day. And we are going to be presenting our friends from the Cleveland Clinic tonight. And if you want some more information about any of our social handles, you can look here. We do have a slight programming change this evening as Dr. Mike Emery had a family emergency and is unable to be with us. However, his content will be covered by Dr. Desai. We are going to hear about multimodality imaging. We are going to be hearing about the standard of RX and genetics. So what are the standards with meds and genetics today? CMIs and new treatments. We know Melinda Desai has been very busy going around the world talking about all these wonderful things happening. He and I were at a meeting this weekend in Houston. He there personally, I there virtually. So we've been doing a lot of work together. And then we're going to hear about surgery from Nick Madeira. And then we're going to hear about EP as well this evening from Dr. Conch. And I think I've got everybody else mentioned here. Now I'm just gonna do one other thing while we get everybody populated as we get going, and we're ahead of schedule, which is something that doesn't typically happen. So let's not jinx ourselves here. I just need to check my agenda and make sure that we've got everything in order. Okay. So I'm going to go first. That's what I wasn't 100% sure of. But before I start the party, I am going to stop sharing my slide for 1 second. And I want to welcome Melinda Sai as the head of the team this evening. And I want to give him an opportunity to say hello and introduce the members of his team the way he'd like to.
Thank you, Lisa. Thank you to the HCMA for everything you have done, you are doing, and you hope to achieve in the future. It is our distinct privilege that you guys have chosen to spend this Heart Month February evening with the Cleveland Clinic, where we work together to raise awareness for the disease. We talk about all the exciting things that are going on in the broad spectrum of HCM, but also specifically within the Cleveland Clinic. And it is, everything in life is a team sport, and you cannot do anything a fraction of what we do without absolutely stellar team members. And it is my privilege to introduce each and every one of my team members. We will start with, in no particular chronologic order, but with Dr. Nick Madeira. He is our cardiac surgeon. All of us know him. He probably has done more myectomies than most, if not all. I would say most living human beings, if not all living human beings. And there's not a darn thing that all of me and my cardiology colleagues cannot throw at him from an HCM perspective that he cannot fix. We've learned a lot. I often joke, if me and Nick spend 15 minutes or 30 minutes talking about something related to HCM, about 9 months later, we have a practice changing paper come out. But we've had a very fruitful partnership over the years. He, then I will obviously introduce Dr. Maran Thamilarasan. He's the solid rock behind our program. He not only is an expert in echocardiography, but an absolutely stellar and astute clinician, and he does a lot with hypertrophic cardiomyopathy. He has done a lot, and he continues to do a lot. And he serves as my sounding board. Anytime I need to run some crazy idea by, I go to his office, talk it over, and often I come out wiser after the discussion. Mo Hange, he's one of my closest allies in electrophysiologist. He's a world-class electrophysiologist. There's nothing, again, similar to Nick in surgery. There's not a single thing that I would not trust Mo to not deliver in terms of electrophysiology. It's pretty much, seldom does my clinic day go by when I just don't pick up the phone and call Mo and, have him see a patient. I come out looking so cool. I'm like, my cardiologist called an electrophysiologist who's going to see me within the hour. There's nothing better feeling than that. And Mo makes certainly me better as part of a cardiology provider, but I would say a lot of us better. From Mo, we move to Bo. Bo is Dr. Zhu is also, he's an advanced imager, multimodality imager, but also has a significant interest in hypertrophic cardiomyopathy and is developing a very good research portfolio of his own. The last two folks, Katie Rutkowski, she is our HCM nurse coordinator, and right now she helps us tremendously in the context of navigating the mavacamten, the REMS program, as well as the new AI ECG Viz platform, etc. So she has done a lot to help our lives. Otherwise, they'll be a lot more complicated than they are. And last but not the least, Sue Ospina. She's my nurse practitioner. I think, in terms of HCM and a few things that I specialize in, I think she's seen more of these patients than pretty much anybody else. She's an invaluable asset to our HCM program, in addition to a lot of other things. Important thing, we have a large research portfolio, and Sue and Katie have helped me deliver a lot of those things along with the rest of our team members. So I think, today we have a full spectrum of folks that help us deliver world-class care at the Cleveland Clinic. And I am Milind Desai. I just show up to work and make sure the trains run on time as it relates to HCM, imaging, and a few other things. So without further ado, I'll hand it back to Lisa. First and foremost, thank you everybody for joining, and hopefully we will have an engaging time through the evening. Lisa.
Milind, thank you so much for that great introduction of your entire amazing team. I have a little programming note to give y'all. I just launched a poll that I literally just wrote while you were talking because something happened to our poll. So take a few minutes and take the poll. Tell us where you're from. Are you looking at treatment options tonight? Are you actively in a clinical trial? And if there's anything that you would like us to cover in future episodes of Tales from the Heart, just give us a verbal answer there. This is not your only opportunity for feedback, but we kind of like to see where people are from. But I didn't have the regular one, so it's going to look a little different on the report. On that note, Susan, thanks for joining.
Lisa,
I see we got
something. I'm looking at the list of attendees, and I do recognize many of our patients. So thank you for joining.
Absolutely. And before I get started here with my presentation, I wanted to recognize two of the HCMA team members who are here tonight. Stacy Titus Brown is our Center of Excellence Coordinator, and she will be available to you in the chat if you have any technical problems working with the software. We won't be doing hand raising. We'll be using the Q&A box in the bottom if you have any questions. For the faculty, if you have any technical issues with the webinar itself, please use the chat feature and Stacy will jump in and help you there. Julie is going to be helping out as well, but I'm going to tell you exactly what you can do to talk to Julie tonight via email. That'll come up in a few minutes, but Julie is our legislative lead and our volunteer coordinator. And we're going to be talking about one of the projects that Julie has been working on a lot. So if you're interested in legislative advocacy, Julie is the staff member that you'll be wanting to talk to. And you'll also be getting some other fun stuff from her tonight. We'll talk about that in just a few minutes. So without further ado, I'm going to give you some quick updates from the HCMA because it's Heart Month. And ladies and gentlemen, we're busy. We got a lot going on here, so stick with us. So here are my updates. Heart Month is here. It is happening. We've got amazing engagement on our social media channels all month long with amazing stories from HCM patients and families worldwide. So if you haven't been following any of our social media, I encourage you to do so. Whether you're a staff member here at the Cleveland Clinic or anybody watching in our webinar world, you know these people. You might be these people. The stories are amazing. They're inspiring. Some of them are a little sad, but they are all the faces of HCM, and we encourage you to get to know them. And we are just about a week away from HCM Awareness Day. We are the last Wednesday in February every year. I'll talk about what states have recognized that in just a moment. But what are we actually going to do on HCM Awareness Day? We're going to do things a little different this year. If you are in the New Jersey area, you are welcome to come out to our office. We are having an open house. You can go room to room and see what we do here at the HCMA. Each one of our team members is going to talk to you about the work that they do every day. And maybe there's some projects that you want to get involved with, or maybe you're just curious to see where we hang out all day and to see if that thing behind me is a real background or virtual. It's real. It's wallpaper, but it looks like brick. So you can come see it for yourself. And we're going to be doing a virtual event simultaneously. So I'm going to be here talking to you on a camera, and there's going to actually be people here in the office seeing what we do all day. So it's going to have a lot of excitement. There's going to be a lot of fun content. We're going to have a little game show. There's an opportunity to win some prizes. The annual meeting will be open, so you can start registering for that. Lots of stuff going on. So if you're coming, if you're coming out this way, you're going to be in Denville, please register and let us know that you're coming so we have enough food. And for any of my locals, I am getting Sergio's to cater in. And if they are from New Jersey and you have anything from the pasta shop in Denville or from Sergio's, you know the food's worth coming out for. So come on out and we're going to have some fun, food, games, prizes. I know it's a heart disease, but hey, you got to have fun sometimes, right? You got to talk about the things that impact our family. So join us online by using this QR code. Come meet us in person using this QR code. So we hope to have you come on out. And oh, by the way, if you like my jewelry, the designer, who is a big-hearted young lady, is going to be here and she will be selling her items, and proceeds come to the HCMA. So you can come hang out and get some fun jewelry. Okay, so that's the event. So I told you Julie's going to be working on a little something else tonight. If you are watching right now and you want an HCM awareness frame for your social media content and you haven't done so already, right now, get on your computer, email Julie the picture that you want, and before the end of this webinar, you will have your frame back to you. So get them in early so Julie has time to do them and process them. So Julie at 4hcm.org, send your photo. She'll pop it in a frame. And by the end of this, you'll have your pictures back. So get yours today. I got mine. My whole team has them. So try to do that. So HCM Awareness Day, if you look at where we started and where we are, we've learned a lot about how to get awareness days through state legislature. So we have proclamations, resolutions, and laws, some of which are in perpetuity and some need to be done every year. So as you can see, our list, our font size has changed. We're smaller now because we've added more states on. So thank you to everybody. Big shout out to Ohio, who was the first to have it, actually second, to have it as a law. New Jersey was first, Ohio was second. Well done, Ohio. So it is a law that we recognize HCM Awareness Day every February. And thank you for that. So what does it mean to have an awareness day? And what does it mean to have a proclamation? It gives us an opportunity to go to the state legislature and say, we recognize this day. Now we must do something for this community. And here's what you can do with your power of legislation to help these families live better lives. And that's kind of what we've been working on for the past couple of months, years here at the HCMA. So we've also gone all the way up to Capitol Hill. We went last February. But this year, because of the change of administration and a lot of change happening in DC, we're holding off until April 9th, when we will go back to the Hill and we will have a legislative briefing in the Rayburn building. If you are interested in joining us, you are welcome to sign up. However, if you're going to be one of our volunteers, you must have already done your intake and navigation call, and then you would be qualified to participate with us on Hill Day. We will be doing a briefing. You're going to hear a little bit about that next week at on HCM Awareness Day. We're going to talk about one of the topics that we're bringing to the Hill, which is about generic drug quality, a matter near and dear to former Cleveland Clinic staff member, Dr. Harry Levers Hart, and he'll be on the podcast or the webinar next week. So we encourage you to get interested in policy, because policy is what drives healthcare today. So we can go do that. On the state, that's the federal level. We don't know the rest of the topics we're talking about on the federal level, for the simple fact that there's a lot of moving targets right now. And we want to figure out where we can find bipartisan support and move something that will be beneficial to our community, whether it's related to access to care for pre-existing conditions, whether it's the generic drug quality issue. We know we're going to go there, but there are other issues that we're trying to see what has the best chance of moving on the federal level. On the state level, you may have heard me previously talk about something called the Healthy Cardiac Monitoring Act. We did a rename, and we renamed it from that to the Children's Cardiac Safety Act, because it better expresses what the law does, what the draft legislation, I should say, does. This is simple. This is us trying to improve the detection of HCM and other genetic heart diseases in the well child examination. For those who are unaware, through the Affordable Care Act, every well child examination is covered by every payer, whether you're Medicaid or private insurance. Every child gets a well child examination every year if a parent brings them in for that opportunity. That visit can cover a lot of different things. What we are seeking is during that visit on the questionnaire, there be questions that are the same questions we're asking of student athletes. Is there a family history of heart disease? Does anybody have devices, transplant, heart failure? Has a child had shortness of breath? These are the 14-point screenings for heart disease as set forth by the American Heart Association, and we use in student athletes. The reality is, of those who die suddenly or unexpectedly from HCM under the age of 24, 80% are not considered athletes. So why are we only providing surveillance for 20%? We should be going for 100%, and that's what the well child exam gets us. We want to create professional development tools for the physicians doing these screenings. We want to improve pre-participation screening physicals for athletes, as each state has a very different approach to how they're doing this. We want a standardized form. We want standardized education. We want communications like we do in New Jersey and several other states. And we want the ability of the healthcare providers to identify families who are at risk and make the appropriate referrals for additional evaluation. They're simple issues. There's nothing controversial here. We are 100% sure that Democrats and Republicans both have hearts and they actually do care about their constituents. So we have some positive messaging here and positive policy work that we are trying to bring forward. If you want to get involved with that, you can contact Julie or go to our website and sign up as a legislative volunteer. So here's hot off the presses. So we have Massachusetts Bill 1738, which is our model legislation, which was introduced. So we now have to get through the committee structure there. Virginia, we are cruising along in Virginia, and we made some progress today too. So we are out of the Senate unanimously. We went to the House. They put some amendments in it in the House Education Committee, and now we're being considered for the full floor. This is amazing. That all happened inside of 30 days. We moved really quick. Rhode Island, we had a hearing last week. Shout out to Matt Grant, who knocked it out of the park with his testimony. Bravo, Matt. And probably saved the bill because of the articulate way he expressed it. So we're under revision right now in the committee. They're working on that bill. We have working legislation, meaning we're working on getting a bill number in Minnesota, Pennsylvania, and Texas. So things are moving. We will have the opportunity to testify at the state houses when bills come up, or maybe even show up for a signing. So stay tuned for more information. And if you want to start to move something in your state, work with Julie in our office and she can help get you set up to learn what you need to do. I am super excited to say that our work on a project that has been a passion project of mine for about the past 4 years, we've gotten the funding in place. Excuse me. And we really are beginning to roll on the All Hearts Collaborative. This is a health equity initiative in which we hope to go into communities of color and help those individuals find their family heart health histories so that they can get the care that they need. This is a unique project as it's not just looking for hypertrophic cardiomyopathy. We're also looking for amyloidosis and uncontrolled hypertension, all issues that impact the Black community very significantly. And we want to start changing the narrative. So we have partnered with a group of clergy individuals in the South Ward of Newark as our pilot project. We are bridging out to build a network of healthcare providers that are in the area and then bridging them to expert care at centers of excellence for both HCM and amyloid, as well as uncontrolled hypertension. This was a project inspired by, honestly, many young Black men that I've seen lost over the years, but it was Derek Armstead that just shattered my heart, as he had had a cardiac arrest witnessed, survived it, got to the emergency room, but nobody asked him about his family heart health history. 5 days later, he passed away. Had somebody asked about his family heart health history, they would have learned that his mother didn't make it to 30. He was 28 years old when he passed away. So if we had looked at mom's family history as being significant, maybe Derek would have gotten a cardiac workup and maybe been admitted to the hospital, instead being discharged 5 days later, having another cardiac arrest. So no more Derek's to the negative, only to the positive. He will never be here to be the dad to his little boy, but we're going to make sure that that little boy grows up in a world that's a little bit more protective of people like himself with bad heart histories in their family. So excited to get that project underway. Stay tuned for more information on that. And we will be bringing All Hearts to other cities around the country, hopefully through 2025 and 2026. If you're watching this webinar and you hear us talk about the power of HCMA recognized Center of Excellence Care, such that you will find out about tonight about the Cleveland Clinic, but you don't have the financial resources to get to a center. If you qualify financially, the HCMA may be able to assist you with a travel scholarship that is actually $599.99 that we are providing to anybody who needs to get to a center of excellence for an evaluation for their diagnosis of HCM or to a transplant program for follow-up care for their HCM. We'll give up to $600 per year, which pays for a plane, train, and an automobile, and maybe a hotel room or food on the road, gas money, whatever you need to get there. We want to lower the burden and help you get to where you need to be to get the care that you need. So if you think that you qualify, you can scan to find out if you're qualified. Scan here. We have wonderful funders. If you want to donate to the Lori Fund, you can make a direct donation. HCMA takes a small processing fee every time we process a grant, but the money basically is from us to whoever qualifies. So if you want to donate, you can donate too by going to the website and looking up the Lori Fund. And you can apply here. Oh, actually, the donate one's up here and the scan one's down there if you want to use QR codes. Podcasting, we've been doing a lot of fun podcasting lately. Last week I did something a little bit different. It was my transplant anniversary of going home with my new heart on Valentine's Day. So if you really want to understand how far back Julie Russo and I go, listen to last week's podcast, because Julie and I have been friends since 1976, and she joined the HCMA back in about 2019, 18, 19. And how did we get here? She was literally the first person that I saw when I was diagnosed with a heart murmur, which I knew to be IHSS at the time. So you want to see the journey from the view of a friend, please watch that podcast. If you want to hear great content from thought leaders in HCM, it's another place to go and just listen and learn in a different way. Or if you want to hear a patient story and laugh, cry, whatever we do that day, please join us. And if you have a topic that you'd like to talk about, feel free to propose it. If we have some time, we can throw in another podcast. It's not that difficult to get it booked. If you have not already done so, our online discussion groups have grown. We're looking to add a few new ones in the next year. If you haven't been to one, these are trained volunteers who can help answer questions, provide resources or direction to resources for living with HCM. We are hosting about 12 groups per month, and this is all volunteer driven. So thanks to all the volunteers who make these things happen. The first week of the month, we do transplant, pre-transplants. The third week of the month, we do pre and post-transplant groups. Then we have device groups, myectomy groups, you name it. If you want to talk about it with HCM, we probably have a group, and I'll be running some genetics groups probably every 2 to 3 months over the next couple of years with deeper dives into genetics. Our ambassador program is growing, and we're ready to take on some new ambassadors. So if you want to share your HCM journey and learn how to advocate for yourself and others using your platform on social media or in your community, we want you to join us as an HCM ambassador. You are required to do your intake and navigation call and then do a volunteer intake. And then we align you with our program, and you get all the access to our other ambassadors around the world right now, because they're not just Americans. So join us. saving the date. We've got some big dates for you to save. We are going to be in person in Orlando on April 25th, Seattle, Washington, July 26th, Baltimore, September 13th, Pittsburgh, November 15th, and in Morristown, New Jersey, October 17th through 19th. And I have an announcement to make about this particular annual meeting. We will be conducting our first HCMA 5K on October 19th in Morristown. So if you're coming out for the meeting, you get to stay and walk, run, or volunteer to work at a 5K on the 19th. So let's pray for good weather and a lot of interested participants in our upcoming first 5K. Website will be open for registration soon. There will be a separate website for the run because you got to get a bib number and all kinds of stuff I know nothing about. I will leave it there with a big thank you to all of our board members who help make us tick every day, our staff members who do the work every day. We have a new staff member, my first webinar since Erica Friedman joined us as our communications manager. So you'll start to see some different comms pieces come out from us. Thanks to our volunteers, our partners, our sponsors, and of course to Brandy, my donor, without whom I would not be able to be with you here tonight. So I'm going to end the poll and I'm going to share the results. I don't know how to share these results. That's very weird because I can't view the details. Okay. So we have people from California, Pittsburgh, Michigan, Ohio, University Heights specifically, Montana, and Australia. Because not everybody answered that. So I will make this back live again. So we asked, there's a whole bunch more. Boston, Morristown, Raleigh, Katy, Texas, Philadelphia. There are a whole bunch here. Cincinnati, Massachusetts, Ohio, Buffalo. I'm not going to get you all. Georgia, Jersey, USA. That's really specific. Lafayette and Long Island. So you're all over the place. Ohio, Illinois, Texas. So we've got the country pretty well covered. Okay. Are you considering new therapies tonight? 26 or 45% of the participants here tonight are thinking about new therapeutic options. So they're shopping and they're looking for the information that our faculty can bring. And we have 17% are participating in a clinical trial. And then I've got all kinds of wonderful topics to consider for another symposium. So thank you for sharing that. I take it back. You guys did a good job. I didn't think there was that many answers so far. So now we are going to hand it off. Who takes over next, Melinda?
I think we'll kick off with imaging with Dr. Boju. We'll start with the imaging piece, how to make the diagnosis. Then Dr. Tham will talk about the current state and genetics. Then me and Mo and Nick. So
I got my agenda now. All right. So we're handing it over to both. Thank you very much. The stage is yours.
Thank you very much. So tonight I'm going to talk about the role of multimodality cardiac imaging in hypertrophic cardiomyopathy. First up, echocardiography is the pivotal primary imaging modality. In terms of diagnosis of HCM, we would like to think of a maximal LV wall thickness greater than or equal to 15 millimeters, or whenever it's 13 to 14 millimeters in the presence of family history or positive genetic testing. As shown here, it's also used to determine the phenotype of HCM, whether it's sigmoid septum, reverse curvature, apical variant, mid-cavity, or simply concentric. It is also used to routinely assess LVUT obstruction, and we'd like to define the presence as well as the severity of obstruction, and generally LVUT gradient higher than 30 millimeters of mercury. We would like to think of that as being significant. Prognosis is very important. So severe LVH greater than or equal to 3 centimeters in thickness, reduced LVEF less than 50%, presence of LV apical aneurysm, and we also use echocardiography to monitor results of treatment, as I'll be showing. Shown here is a patient of mine who has, as you can appreciate, severe systolic anterior motion of the mitral valve associated with dynamic LVOT obstruction. When we assess our echo systolic anterior motion, we would like to assess it by the degree of septal contact. And severe SEM, generally, we would like to quantify that as having full septal contact as shown here in this case. It is also vital to assess the degree of concomitant mitral valve regurgitation. Often in SAM-related regurgitation in HOCM, it is posteriorly directed. On Doppler here, this is a signal of mitral valve regurgitation. Now, I've also shown the various dynamic gradient profiles on echo. It's very important to differentiate on Doppler between dynamic gradients, which are generally dagger-shaped, versus mitral valve regurgitation. To highlight the role of exercise stress echocardiography, which myself and my colleagues routinely use as a diagnostic strategy to unravel dynamic LVOT obstruction, shown here, as you can see, following exercise, this patient has severe STEM with septal contact with a very significant dramatic LVOT gradient of 174 mmHg. To illustrate the role of echo in various morphologies of HCM, this is a patient of mine with severe apical hypertrophic cardiomyopathy. As is shown here, severe apical hypertrophy is demonstrated. Very interestingly, this patient actually turned out also to have a subaortic membrane, which results in what's known as fixed subaortic obstruction. As shown here on Doppler, there is an elevated gradient, which is fixed in profile and very different to the dynamic case of HOCM shown before. There are other morphologies. This is another patient that I've met with a mid-ventricle variant of obstruction. As shown here, the flow convergence and acceleration is in the middle part of the ventricle rather than LVOT. Again, following amyl nitrite, which is an agent we use to provoke obstruction, there's a dynamic gradient that's very significant. Goal-directed Valsalva is a new maneuver that's advocated and certainly included in the American Society of Echocardiography guidelines. And we are using this more routinely at the Cleveland Clinic now for new patients. Simply, this is something that will help patients perform Valsalva when the routine Valsalva is not very clear and there's variability. We do that by using a disposable 10 ml syringe and connect that to a blood pressure manometer cuff. And we get the patient to blow into the syringe, maintaining a pressure of 40 mmHg for 10 seconds or longer. As shown on the right-hand side, in this case, after the goal-directed Valsalva, there's a much higher dynamic gradient being provoked. It's very important for prognosis. This is a patient of mine, as you can see, with massive left ventricular hypertrophy, measuring 3.7 centimeters, and very elevated scar on MRI, which we'll talk about. And he's gone on to have an implantable defibrillator for primary prevention. In terms of echo, it's also very important to define the presence or absence of the apical aneurysm, which is yet another prognostic factor. The patient here is shown to have a clear apical aneurysm, and on color Doppler assessment and post-Doppler, you see the nice diastolic flow from the apical aneurysm. Reduced LVEF is also very important to consider. A patient of mine who had obstructive HCM many years ago, status post-myectomy at an outside hospital, subsequent ICD, left bundle branch block, and deteriorating LVEF of 40%. He presented with recurrent VT status post-ablation and has had CRT device upgrade. Currently, he's under evaluation for advanced therapies. In terms of monitoring of treatment response, this is also very important. This is a patient of mine who had prior alcohol septal ablation at an outside hospital. As can be seen, the result of the prior procedure was not great, as the patient still had a significant dynamic gradient following Valsalva. We use it routinely to assess the effect of mavacamten, the new agent that's used for relevant and suitable patients. This is a patient of mine with significant obstruction prior, and clearly following treatment, there is eradication of the dynamic gradients as shown here on echo. And also another patient of mine here who's being operated on by Dr. Madeira with a dynamic gradient that's very elevated, with excellent post-surgical results and eradication of the dynamic obstruction and symptoms after surgery. In terms of the updated guidelines for HCM released in 2024, there is also now increasing recognition that cardiac MRI is an important complementary imaging modality in HCM. The strengths of MRI are that it offers comprehensive evaluation of ventricular wall thickness and geometry of LV hypertrophy. It's considered the gold standard for quantification of ventricle size and function. It allows us to assess the mitral valve and subvalvular apparatus, including SAM. It's also able to assess the anatomy of the papillary muscles, as well as apical aneurysm, and importantly, LGE, or late gadolinium enhancement, which I'll talk about. When to consider cardiac MRI according to the guidelines? We should use MRI when patients having suspected HCM, yet the echo assessment is inconclusive. Or we want to use it to assess alternative diagnoses, so in causes for left ventricular hypertrophy and thickened myocardium. And these include cardiac amyloidosis, hypertensive heart disease, and patients having athlete's heart. We also use MRI routinely to help evaluate and make decisions regarding implantable cardioverter defibrillator therapy to assess the prognosis and scar. Also, we use MRI to consider the anatomic mechanism for obstruction. Shown here is what's known as the short axis CNA stack. As can be seen, it allows us to look at the whole heart in granular detail, quantifying the thickness and heart function. And this is a young patient that we looked after, aged in his mid-30s with exertional chest pain. As shown here, MRI allows very accurate quantification of the wall thickness, as well as mitral valve regurgitation, which in this case is quantified to be moderate with a regurgitant fraction of 27%. LGE is a very important factor here to consider. For this patient as shown here on the scar imaging, there is elevated scar burden of 20.4%, meaning that there is an increased risk for potentially life-threatening ventricular arrhythmias, therefore warranting consideration of potential ICD. Work done here at the Cleveland Clinic, led by Dr. Desai, showed previously that elevated scar burden greater than or equal to 15%, as defined by MRI, was associated with worse outcomes across all groups of HCM patients. It's important to remember that not all HOCM patients have severely thickened walls. This is a patient that we looked after here. As shown here on MRI, hypertrophy is only minimal at 1.3 centimeters. However, the main problem is that the patient has prominent multi-headed papillary muscles with a very mobile anterior head of the posterior medial papillary muscle. Therefore, the pap muscle abnormality, the elongated anterior mitral valve leaflet, all contribute towards the SAM and significant LVOT flow obstruction. It's always important to remember that not all thick walls are due to hypertrophic cardiomyopathy. This is an older gentleman who was referred for assessment. As can be seen, ventricle walls are thickened with reduced LVEF and global systolic dysfunction. On scar imaging, however, there is diffusely an abnormal increased signal in the left ventricle and right ventricle with elevated T1 time, and this is a patient who turned out to have cardiac amyloidosis. Not all HCM cases are associated with obstruction, as I've talked about, and this is a patient with apical variant hypertrophic cardiomyopathy. On scar imaging, there's severe LGE at LV apex with suggestion of a small LV apical aneurysm. This is another patient of mine with a large LV apical aneurysm who actually subsequently, unfortunately, developed LV apical thrombus, very nicely demonstrated here on MRI. Potential limitations and contraindications in terms of availability and technical expertise, elevated cost, presence of existing pacing or defibrillator devices in some cases, acute kidney dysfunction, claustrophobia, arrhythmia, and hemodynamic instability. And lastly, I'm going to briefly mention cardiac CT. CT is used less commonly compared to echo and cardiac MRI in HCM. However, it's able to provide additional information in certain cases, especially when it comes to assessment of coronary artery anatomy in terms of assessment of myocardial bridges, which are not uncommonly encountered in HCM, as well as anomalous coronary arteries. And we routinely use cardiac CT for preoperative planning, especially in redo cardiac surgery, to define the relationship of cardiac structures to the sternum and assessing the aorta for calcification. Shown here is a patient of mine with apical hypertrophic cardiomyopathy. Very interestingly, as you can see, that the patient has an anomalous coronary arteries in that this lady has a single coronary artery circulation. Her RCA actually comes off as a branch from the left system. This is another example of a patient with a prominent mid-LAD myocardial bridge, demonstrated here nicely on cardiac CT imaging and corresponding coronary angiography, which is important to define preoperatively. Shown here is an older patient with prior aortic valve replacement and subaortic membrane resection being considered for potential redo surgery. However, as you can appreciate, the aorta is diffusely severely calcified, and this is termed the porcelain aorta, which is a very high-risk imaging feature for potential heart surgery. Potential limitations for CT, obviously there's always radiation exposure. Whenever we assess coronary arteries, it requires contrast, can be a problem for patients with kidney dysfunction, and generally temporal resolution is inferior considered to echocardiography. In summary, echocardiography is the primary imaging modality for the diagnosis of HCM and assessment of LVOT obstruction. Cardiac MRI imaging is a very important complementary advanced imaging modality for hypertrophic cardiomyopathy, as I discussed. Cardiac CT is less frequently used in HCM, however, it can be helpful for assessment of coronary artery anatomy and for preoperative planning. And I thank you very much for listening.
Thank you very much. I want to just give a shout out to covering amyloidosis in the imaging of HCM. We've learned so much more about how amyloid has kind of even been hiding within the HCM space, undiagnosed for a long time. So we know that 6% of non-obstructed patients in a large cohort were actually found to have amyloid, where both imaging and I think genetics play a big role there. So just thanks for including that. I thought that was really interesting. Malind, off to you to pivot to your team.
Next, I think we will hear from Dr. Tamala Arasan. He'll talk about medical treatments, some of the standard treatments, as well as he'll touch a bit on genetics. Marin.
All right. Thanks, Melin, and thanks, Lisa, for this opportunity and all the work you've done over the years for all these patients and all of those to come here. So I'm fantastic foundations of medical therapy. So we'll go back a few years here with this. And so what is the goal of really medical therapy? And really is to make people feel better. And there are a lot of things that can cause symptoms, and we'll kind of go through some of those and why we pick certain medications for that. Now, up until recently, none of the data suggests that any of the historically available medications alter the natural history of HCM, but they make people feel better. And so how we decide on medicines, we kind of look at three parameters. We look at either obstruction, no obstruction, and overall left ventricular function here. So we basically talk about treatment, we're talking about different manifestations of HCM. So we heard that a good number of people have obstruction, and so we kind of target that. But it's also other things that cause symptoms as well too. And the things called diastolic dysfunction, with hearts just a little bit stiffer and thicker and a hard time relaxing because of the increased muscle mass. They can be what's called microvascular dysfunction, which is some of the smaller capillaries in the arteries. So the main arteries could have blockages, we talk about CAD, but oftentimes the main coronaries themselves may be fine, but the little capillaries may have little difficulties in terms of regulation and vasodilation, which can cause some symptoms of chest discomfort as well. And overall, in this condition, because of the increased thickness of the heart muscle, there can be increased myocardial oxygen demand that can lead to symptoms as well too. And if there's fluid overload, we can see congestion as well. So this is from the recent last year's ACC/AHA guidelines in terms of medical therapy. And if you see sort of the brand point is, we first look, is there obstruction and obstruction? And for obstruction, that's not just rest, it's also Valsalva, the goal-directed Valsalva Dr. Zhu discussed, as well as exercise. And if we identify obstructive physiology, and the question is, do people have symptoms with that? And we don't just treat a number, but if that obstruction leads to symptoms of effort intolerance, shortness of breath, or chest discomfort, then we do want to do things to try to make people feel better. Now, the first thing we do is we try to avoid medicines that could make this worse. And particularly, there are a lot of agents for blood pressure called vasodilators, which are good for blood pressure, but in response to the vasodilation, the heart can beat more vigorously. So a lot of times, things that we say are good for overall blood pressure, like ACE inhibitors or called dihydropyridine calcium antagonists, may not be the best choice there. And so we usually will try to transition off of these two agents, particularly our first line is called a beta blocker, in particular we call non-vasodilating beta blockers. The metoprolol, atenolol are probably the prototypical examples of this. There's another beta blocker called Coreg or carvedilol, which also has an alpha property to it, and we generally don't want to use that because that can make the obstruction worse, although we use Coreg quite frequently in patients with congestive heart failure. And those people who don't tolerate beta blockers can cause some fatigue. Then typically calcium channel blockers such as verapamil or dithiazem can use to also lower the heart rate and contractility. Now, those who have very high gradients at rest, we kind of worry a little bit about verapamil because there is some vasodilatory properties. And you can use diuretics if needed with hypertrophic cardiomyopathy, particularly as evidence of fluid congestion, but you don't want to cause intravascular depletion or get the heart too dry, because that can cause obstruction to occur. So let's talk about beta blockers, which is probably the mainstay, and this really dates back to the 1960s. And Dr. Braunwald at Harvard, who made the initial kind of seminal observations and describing this condition, even back in the 1960s, showed that things that make the heart contract more vigorously cause the obstruction to get worse. Things that cause the heart volume to get smaller will cause the obstruction to get worse as well. So he thought a beta blocker would be a good idea to try to treat these. And so this was his first series back in 1967, looking at propranolol, which was the first beta blocker used. And he had 8 patients whose main symptom was chest discomfort, and he put them on propranolol and kind of titrated. And he tried to see how they improved or not. What he found was he put them on a treadmill and saw that about 5 of those 8 patients could go further on the treadmill without having symptoms of chest discomfort. And so based on that, beta blockers were sort of introduced in the treatment for hypertrophic cardiomyopathy. Obstructive at that time, but also use it for non-obstructive as well. And even though that was back in the 1960s, we didn't have actually a randomized trial of metoprolol till about 40 plus odd years later. And what this did show basically was that it can, this is a study, I won't go through all the details, but basically it did show that beta blockers can reduce the gradient, both Valsalva and exercise, and people do feel better there. Their access capacity may not have been improved, and something called a BNP level, it's a marker of stress, may not have improved, but it did overall improve symptom and effort tolerance. And that's why we kind of use beta blockers as our first line therapy. Now, for some people, we do push the beta blockers, but the heart rate may still be elevated, or there can be intolerance to the beta blocker, could be side effects. And so the thought was, could we also use calcium channel blockers? And this goes back to the 1970s. We're also looking at verapamil, looking at the same way, but 12 out of 19 patients showed a reduction in gradients and so forth. So I introduced, there were other testing, so exercise testing, verapamil in the cath lab, also which showed a hemodynamic benefit as well. And this is back to the mid-1980s, kind of a summary of about 233 patients who were on calcium channel blockers. About 16 didn't tolerate it, came off of it, 71 stopped, no clinical benefit. And so the remaining 126, we can see most people did get some improvement in functional class there. So those kind of our 2 therapies. Now, there's been some data that maybe in people who have early onset HCM, some genetic abnormalities, that maybe some medications might help with that. So there's one suggestion that maybe diltiazem may help with some with those with mild hypertrophy at an early stage. This remains to be seen, but certainly in somebody who has sort of early early diagnose HCM, and now that we do a lot of genetic testing and find people at a very early stage, for those with mild hypertrophy who may have also concomitant hypertension, this might be an agent to consider because there might be some additional benefits outside of blood pressure control. Through that there. Now, if you go back to our guidelines again, see the first line therapy of the beta blockers or the calcium blockers, and then if symptoms persist, back before the recent years, options with disopyramide are talking about proceeding with cardiac surgery. And disopyramide, again, been used a long time, been over 40 years now, and basically it's an antiarrhythmic agent that was designed many years ago. It's not as effective to treat atrial fibrillation, but it does have what I call a negative inotrope. It does make the heart beat less vigorously. And it's been shown by having that, introducing that, you can further reduce the gradient. And Dr. Sheridan in New York is probably the biggest user of these agents, and he has published both the safety and efficacy of these agents. And what they found was about a 50% reduction in the gradient, and about 2/3 of patients did tolerate the medication there. It does not prove to it doesn't seem to have any negative adverse effects in terms of increasing risk here. And this is a review from about a decade ago. About 299 patients that were both on beta blocker and or verapamil or some combination and still had obstruction and still had symptoms. About 63 went off to have surgery. Another 221, they added the disopyramide there. And about 80 of those still had obstruction, ended up needing either surgery or alcohol ablation. But about 141, there was a sustained symptomatic and obstruction benefit in obstruction there, and seemed to be an equivalent survival curve in that. The main side effects are the symptoms an anticholinergic, so it can cause symptoms of dry mouth and urinary hesitancy, constipation, and those with glaucoma can be impacted by this. And a drug called pyridostigmine, which can help with the side effects. But generally speaking, it isn't a third agent that can be used. And we haven't used it a lot here, but part of that's probably because of our excellent surgical expertise, that those who have obstruction don't respond to standard therapy. We've sent to surgery. And of course, now Dr. Desai will talk about myosin inhibition, which has definitely changed the game here as well. I'll kind of briefly talk about non-obstructive HOCM. I say a good number of patients do have obstruction if you look hard enough, but about a third or so will not have any obstruction. But they can still have, you can still have symptoms with this, again, because of some shortness of breath can occur, chest discomfort can occur. And the management of this can be somewhat challenging. We still use beta blockers and calcium antagonists. They kind of ideas, they slow the heart rate down, reduce the oxygen demand of the heart, and sometimes can therefore reduce some of the symptoms there. Now, we don't want to lower the heart rate too much. Sometimes when the heart's very thick and stiff, we don't want to lower the heart rate too much because the heart needs that extra heart rate to generate cardiac output. And oftentimes people will have symptoms of congestion, so we can use the diuretics in these settings if there's evidence for volume overload. There are agents in a class called MRA, or mineral receptor corticoid, and aldosterone is an example of that, and this can help there as well. And a lot of this is from data on people who have what's called heart failure preserved EF. And there's a patient with hypertension, diabetes, whose the heart contracts normally, ejects normally, but they have symptoms from the heart being a little bit stiff. And these agents, diuretic with aldosterone, which is a potassium-sparing diuretic, and a medicine for diabetes, as you've probably seen the ads for on TV, everyone's singing about, is called Jardiance. It's also been shown to be beneficial. Now, a lot of these trials have not necessarily included patients with hypertrophic cardiomyopathy, but oftentimes in non-obstructive, we may extrapolate to try to help with symptom relief. And the data has been on mixed-on spironolactone. There hasn't been any necessarily changes ultrastructurally, but it can help. There's now the angiotensin receptor blockers are basically vasodilating agents, and those who have obstruction, like we talked about briefly, are not good agents, can make the obstruction worse. But in those without obstruction, there may be some role for this. And there's been a mouse model of hypertrophic cardiomyopathy which showed that if you give it early enough, it may change the histologic progression of this. And there was a trial called the Vanish HCM trial, with basically individuals with early stage HCM, oftentimes genetically positive, found to have early onset to LVH. And some thought that maybe this agent might help forestall some of the progression. So again, this might be a good agent for those who are non-obstructive early and who have hypertension as well. And these are just kind of the guys, I won't go through this, but just for reference, kind of that these are kind of our stepwise guidelines we can use in terms of treatments. Again, the K beta blockers, calcium blockers, considered diuretics in all these medicines as well. And doctors, you briefly associated this, that in HCM with non-obstruction, the ejection fraction drops below 50%. We do see more adverse events, and we treat these patients very similar to those who have congestive heart failure of any etiology, with different sets of medications that are used specifically in the setting of a weakened heart, in particularly, and also consider ICE defibrillators and CRT as well here. So kind of summary of medical therapy after still almost a half century, beta blockers and calcium blockers remain sort of initial line therapy. And we do see symptomatic benefit in a reasonable number of patients, particularly those with obstruction. Norpace has been shown to be of some benefit in those with not-responding beta blockers or calcium blockers. Obviously, now we're in a new age with the myosin inhibitors, Dr. Desai will review in more detail here. Those with non-obstructive HCM who have symptoms is still a very difficult management strategy. We talked about these various agents, and I know Dr. Desai now we've done the Odyssey trial to see if myosin inhibitors might be beneficial in this, and we eagerly await the data on this. And those with weakened hearts, we kind of treat in a different pathway. I'll talk about genetics. I won't do this too long because I know I'm kind of going over here already, but these are the kind of all the different things that genetically can cause HCM. And this is now more relevant because we're in the age of genetic therapy. Identifying what the mutation is certainly is very valuable to help us maybe potentially targeting this. And this is from a recent review saying all the genes that have been associated with HCM, both definitively and most likely. And likewise, also, there are, we call it the HCM phenocopies, things that echo-wise may look like HCM, but are not HCM. Amyloid is one example of that. Also, glycogen storage disease, Anderson Fabry. And it's very important because it's an entirely different treatment pathway. So it's important that we identify this as well. And again, I'll flip through these quickly. I think it's too much to add. So I think I'll stop here and we can certainly answer any questions later as well, too.
Thank you very much, Maren. That was a tour de force of therapy and leaving off with the exciting addition of gene therapy. That is exciting. Okay, there we go. We've got your share screen down. Linda, I hand it back to you.
Can you see my slides?
Not quite yet.
About now?
Now
Yeah.
we're good. Thank you.
Perfect. Thanks again. Thanks, Maren. So now I will walk you guys through. So as I alluded to, I have my talk into two parts. One is my talk, and then a little bit of the sports and exercise, etc. So I'm Milind Desai, and I will talk about first cardiac myosin inhibitors. So, as Maren Dr. Thamillarasan has alluded to, what were the pre-CMI medical treatment options? A lot of them, but as has been said, do not target the disease process, may not provide sufficient symptom relief, and often have some side effect issues. Cardiac myosin inhibitors have been a game changer, with mavacamten being the first in class. Essentially, they target the hypertrophic cardiomyopathy sarcomere. The heart is in a state of hypercontractility and does not utilize energy efficiently. By impacting directly on the heart muscle, it takes the edge of hypercontractility and makes the heart function better. Mavacamten is obviously the first in class, and aficamten is currently undergoing testing or currently undergoing regulatory review for hopefully approval. Little longer half-life for mavacamten, between 6 to 9 days, and 3 to 4 days for aficamten. Both these drugs have little arrhythmogenic potential. Mavacamten, so meaning arrhythmia causing problems. Mavacamten is metabolized through the liver pathway, and there could be possibility of drug-drug interactions, and aficamten has yet to report such interactions. So I'm going to quickly walk you through where the data is. So for the first time now, we have all these what we call phase 3 randomized trials, which means the drug, be it mavacamten or aficamten, has been tested against a placebo or a sugar pill. So that's the purest form of research, with Explorer HCM being the first one, Explorer China done in Asian patients, Valor HCM, which we led, that was in patients with advanced disease who were referred for septal reduction therapy, and Sequoia, which was looking at aficamten. The first 3 trials were mavacamten. Sequoia is looking at aficamten. We are here in 2025, and this is rapidly evolving. What did the results show? This is a busy slide, but I'm going to summarize for you in a second. Compared to placebo, every endpoint that was looked at, mavacamten or aficamten, was grossly positive. So these drugs make you feel better, meaning shortness of breath. They make you exercise more. They make your gradients go down significantly more compared to placebo. And in case of Valor study, it showed that at 16 weeks, only after 16 weeks of taking therapy, compared to placebo, 8 out of 10 patients no longer met criteria for cardiac surgery or alcohol septal ablation. So these are the fundamental primary endpoints of these trials. Additionally, patients, more than half the patients, almost 60% of patients in all the trials, had at least one class in functional improvement. However, one thing, I'm all about showing the pros and the cons. And why do we not just rely on NYHA class or functional class alone? Because even we showed in all the trials between 15 to 30% had a placebo effect, meaning if you, the patient, wants to feel better, even if you're on a sugar pill, you may think you are feeling better, which is why we require other things like stress testing, etc. Biomarkers like pro-BNP improved significantly compared to placebo. Quality of life. It is about quality of life, and FDA approves this as a bona fide marker. Across the board, compared to placebo, Explorer, Valor, Sequoia, the quality of life measured by Kansas City Cardiomyopathy Questionnaire was significantly improved in the patients taking drug versus placebo. In the bottom panel, we even published results at up to 1 year from the Valor study. Again, the effects are sustained over a year or even longer worth of follow-up. This is a busy slide. Don't need to worry about it, but every aspect of echocardiography, your gradient, your left upper chamber size, your stiffness index or diastolic dysfunction, your mass, everything significantly improved on MAVA or aficamten compared to placebo. Something new we just presented a few months ago, strain. Strain is a novel way it measures regional cardiac function on echo or MRI. Mavacamten compared to placebo significantly improved left upper chamber as well as LV strain. So not only is this drug helping with the gradients, but it is making a fundamental improvement in your cardiac structure. So the longer term impact, in my opinion, is going to be beyond the gradient relief. Cardiac MRI has shown both in aficamten and mavacamten that it stabilizes myocardial fibrosis or the scarring, but also results in thinning in shrinkage of the excessive thickness. So MRI can be used as a way to follow up these patients longer term. Safety. Again, these are cardiac myosin inhibitors, meaning they are going to inhibit the heart muscle, but overall the signal across the board, your ejection fraction, if you are normal or hypernormal EF, the reduction in function is about 4%. Interestingly, majority of the patients treated with mavacamten in all the 3 trials, they achieved maximum efficacy at the lowest doses. Aficamten has a different pharmacodynamic mechanism, and it required slightly higher doses for optimal impact. But across the board, safety signals have been favorable. What is the long-term data? Again, this is not a short-term gig. In the Explorer study, up to 180 weeks, the effects were sustained. So if you are on the drug, your positive impact is sustained without any additional safety signal. Quality of life, gradients, everything remains within normal. Valor study, we presented this at 128 weeks. Remember, every patient referred for Valor study was a candidate for surgery or alcohol septal ablation. At 128 weeks, only 7 patients underwent surgery. Everybody else continued on commercial mavacamten, and there was a sustained improvement in their health status as well as biomarkers. So all this, what all this has done is now the guidelines recommend that it's a class 1 indication. If you are a beta blocker, but if your symptoms persist, you can go to mavacamten or alcohol or septal reduction therapy. At the Cleveland Clinic, we don't typically use disopyramide. Never really have been big users of that. So MAVA was launched in April 2022. I remember me and Lisa had a podcast the day of or the day after. Ideal patient is a symptomatic patient with obstructive HCM who's still symptomatic despite being on 1 background therapy. And this was obviously because of concerns about ejection fraction drop, launched under the REMS program, which is mandatory in United States. Now, the advantage, you always utilize things towards your advantage. The advantage of the REMS program, there may be some disadvantages or whatever challenges early on, but advantage is now we have the world's largest database on echo in hypertrophic cardiomyopathy. So we presented this data in more than 6,000 patients. So if the folks that are on this call, if you are on mavacamten, your data we presented. We have the data that you submitted to REMS program. What we found was that the rate of ejection fraction drop to less than 50% was only about 4.6%. Heart failure hospitalization was 1.3%. There were 29,000 forms submitted, and the EF drop was less than 50%, was noted in less than 1% patients. Patients who were treated with 1 year or more of treatment, almost 2,000. Same proportion of patients had EF drop, which is less than about 4%. There were 52,000 drug interaction checklists completed, and the problem that required mavacamten dose reduction was only 0.25%. So the REMS program has taught us a lot of important lessons as to how to manage these patients, but also importantly, the issues with heart failure is essentially a non-issue. Dosage. Again, as similar to the trials, majority of the patients were treated, 75% treated at the lowest doses of mavacamten. Only 5% required the highest dose. And 95% of the 730 patients who required a reduction in dose was because of an excellent response to mavacamten, not because of a side effect. Gradients, again, excellent response after treatment. So we published our first 150 patients treated at the Cleveland Clinic. 3 patients required temporary discontinuation, and sorry to disappoint Nick, but of these 150 patients, not one of them has needed septal reduction therapy. There were 40 patients we saw who had no symptomatic improvement, yet their gradients were normalized, which means their symptoms were coming predominantly from diastolic dysfunction or stiffness of the heart. And you'll hear from our nurse and nurse practitioners soon, we managed to navigate the logistic complexity in a very nice way. In fact, more than a third of our patients are from out of Ohio. And a lot of them send us their follow-up echoes that are done locally. Every patient that needed mavacamten, we were able to provide access to mavacamten based in the real world study. So what's coming next is all these trials, the Odyssey trial and Acacia trial, Odyssey in MAVA and Acacia in aficamten in non-obstructive HCM. Sonata is looking at a different molecule that, again, in non-obstructive HCM patients. So the future is truly bright. Lisa alluded to an exciting thing, and Cleveland Clinic is leading the charge here. Again, we performed the world's first gene therapy for HCM, myosin binding protein C, and we have 3 patients in this study that is ongoing, and hopefully we'll have more results in the next year or so. Some newer molecules, I have a hard time pronouncing this, nirafaxstat. This is a newer stuff that works on energy metabolic, cardiac energetics, and hopefully we will have some good stuff in the context of this molecule. So with that, I'll pivot to Dr. Emery's talk. He could not be with us. This is an important part of discussion. All of you have been a part of this. Sudden cardiac death in athletes, the majority of the highest proportion, if you ask me, is in hypertrophic cardiomyopathy, at least in US registry. In clinical practice, unfortunately, in the past, the message has been confusing because of wrong or suboptimal advice. Folks with HCM tend to be less active than the US population. And obviously, not being physically active is generally not good for your emotional well-being. So where is the data? Again, once we looked at real data in terms of a prospective registry, which is the Live HCM registry, we did not find any difference in long-term survival between folks who do not exercise versus vigorous exercise or non-vigorous exercise, which means under watchful, after shared decision-making and appropriate discussion, aerobic activities, at least I certainly do not put any restrictions on aerobic activities in patients with hypertrophic cardiomyopathy. And again, the guidelines recommend that. Class 1 indication for low to moderate intensity and a shared decision-making type approach for competing high-end athletes. So again, where's the data for the Matt Martinez presented this data in Division I and professional athletes, and these folks were initially disqualified, but the 73 or 96% patients chose to return to play with 0 deaths. So this is these evolving recommendations have been a game changer in how we look at these patients. So what are some of the other, forget the routine athletes. What about the standard weekend warriors? We do not recommend any restrictions on aerobic physical activity. Pregnancy, all those things, shared decision-making is important. What is more important is working on your comorbidities because they are a bad actor in this context. So the other aspect is, again, I started by saying this is a team sport, not just athlete, but a patient. It is the family, physician, cardiovascular expert, trainers, and many other stakeholders are important in decision-making or helping navigate the journey. Bottom line is shared decision-making. Okay, and developing a plan where you return to play and return to exercise. There are resources available. HCMA has resources. American College of Cardiology, AHA is coming up with resources which can help you and your team and your doctors, if they're uncomfortable, set up a program. But when in doubt, seek out a center of excellence because there's expertise available that can guide you safely through these programs. Another important thing is again, I'm not a pediatrician, but the pre-participation physical evaluation is an important part. Lisa was talking about it a few minutes ago at the introduction, and a lot of work is going into these physical evaluations at a childhood level, so that we not only make the diagnosis, but give appropriate guidance starting from the beginning. What about screening? Asymptomatic first-degree relatives, as many of you have experienced this, children need to be screened every 1 to 2 years, adults every 3 to 5 years, and typically it is recommended that you get screened by EKG and echocardiography. Genetics, Dr. Tham talked about it, but genetics do play an important role in screening. So if you, the patient, is gene positive, then it makes sense for your first degree relatives to be tested. If you are gene negative, or you have variant of uncertain significance, then it is recommended that your family members undergo imaging and ECG-based testing. What I always tell my patients is there's new stuff always happening, so let's revisit this every 3 to 5 years and get repeat testing as new genetic mutations may have been discovered. So one last thing, this is a new thing that is coming. We have employed this in the last few months, is we are using artificial intelligence to identify ECGs that may be flagged so that we can work them up for hypertrophic cardiomyopathy. In our first 85,000 ECGs in the first 6 months, we analyzed 42,000 patients at main campus in Cleveland Clinic. We found about 60 new HCM patients out of the 1,200 flagged. Imagine if we have 50 to 60 new patients, undiagnosed patients floating around in our system at main campus Cleveland Clinic. What's the state of the affairs a lot of other places? So we are excited, and this is now part of our mainstream workflow. I'll end by showing this case that highlights two of the things I've talked about. This is a 61-year-old executive. He's been having executive physicals for the longest amount of time. Symptomatic, positional dizziness. He was told he has plaque buildup on his calcium score, high blood pressure, dyslipidemia. Other than that, nothing else. But he underwent an AI ECG, artificial intelligence ECG evaluation as part of our new initiative with Viz AI, and his ECG was flagged for HCM. I understand you guys are not cardiologists, but this ECG does not look like HCM. So no wonder he was missed. Subsequently, once we identified this ECG was flagged, he was referred for workup. And I saw this gentleman in the clinic, and he clearly has hypertrophic obstructive cardiomyopathy. He was missed for the longest period of time. He was not interested in surgery, so we initiated him on mavacamten with relief of his symptoms, and he's now in NYHA class 1, totally asymptomatic. Bottom line is we leverage novel technology to treat him with novel therapy. So this is modern hypertrophic cardiomyopathy, the way we practice at the Cleveland Clinic. You will hear from my nurse practitioner, Sue, as well as Katie in a little bit, but just I'm putting up our numbers in case you want to reach out to us. I will stop here, and I think I will introduce Dr. Kanj, who will bring us up to date on all things electrophysiology. Mo.
Thank you so very much, Milind, for this very kind introduction. Thank you, Lisa, for the invitation. So I was asked to give you guys a talk about management of atrial as well as ventricular arrhythmias, as well as device therapies in 10 minutes and using only 10 slides. So let's see if we'll be able to do it. So, okay, I'm going to try to move my screen. I think, Milind, you may have to give me access. Or somebody
I think
has
you're
to
good.
You're good. You have access. It's your screen.
but for some reason it's not moving.
Okay,
Let-
so let's take you off a screen share and restart
I'm
it.
gonna try to do it one more time.
Yep.
Okay, this is. I'm gonna do one more time. Okay. Can you
Beautiful.
see me now?
We've
Okay,
got it.
perfect.
Yeah.
Okay, excellent. So we'll do this. Okay, so sorry, I lose my screen one more time. Okay, I'm gonna do it one last time. I'm sorry about this. Okay, we'll do this. We'll do this, and we'll do share. Okay. So first, we're going to need to talk about sudden cardiac death because this is the number one reason why patients unfortunately die who have hypertrophic cardiomyopathy. We know that there are a lot of risk factors that can predispose patients with hypertrophic cardiomyopathy to sudden cardiac death. And again, sudden cardiac death is not myocardial infarction, is patients suddenly die. And usually this is the result of what we call ventricular arrhythmia, where the bottom part of the heart starts racing. And when the bottom part of the heart racing, it does not have enough pumping function. So less blood is being pumped forward, so less blood to the brain, and that would result to death or people passing out. There are a lot of risk factors that can predispose a certain individual to this sudden cardiac death. I've listed some of them, like youth, younger individual, family history of sudden cardiac death. For example, a family history who died at the age of 50 or younger could be a first relative, a second degree relative, patients who have advanced heart failure, patients who don't have a good exercise capacity, patients who have already passed out before, patients who have very thick left ventricle, patients who had a gradient, meaning there's, as we mentioned from our previous speakers, there's an obstruction that preventing blood to go through that to the aortic valve, diastolic dysfunction, meaning stiff heart and blood accumulating in the ventricle, causing shortness of breath, inability to exercise or increase the blood pressure with exercise, ischemia, atrial fibrillation, non-sustained ventricular arrhythmia, or positive MRI, where we see a lot of scar on the MRI. All of these factors are actually increases the patient's risk to die suddenly. However, there are very few that increases the risk of sudden cardiac death at a much higher level. These are the 5 that I just listed, like family history of sudden cardiac death, syncope, severe left ventricular hypertrophy, inability to increase the blood pressure, non-sustained VT, as well as positive MRI. So if you take, for example, somebody who previously died and you watched him from not aborted death from ventricular arrhythmia, you'll find that the risk of them having another lethal ventricular arrhythmia in the next 4 years is up to like 40%. But we don't want to do that. We don't want to wait for somebody to have a lethal ventricular arrhythmia. In our clinic, we want to try to prevent that. We want to try to catch these people who we think they are at increased risk of sudden cardiac death. And these are the things that I look at when I chat with my patients. So what are the guidelines? What are the consensus? How do I make a decision whether somebody needs a defibrillator or don't need a defibrillator? First thing I do is I ask them whether they've had aborted sudden cardiac death, or they've had what we call sustained ventricular tachycardia or ventricular fibrillation, where it was aborted by using a defibrillator. If they've had it, then definitely they need a defibrillator. And they did not have it, I start looking for these major risk factors that I talked to you about that will predispose somebody to increase sudden cardiac death. And this is family history of sudden cardiac death, massive left ventricular hypertrophy, meaning the thickness is more than 28 millimeter, unexplained syncope, apical aneurysm, where there's a part of the ventricle, as Dr. Zhu mentioned earlier, there's the tip part of the ventricle is dead, is not moving, there's enough scar in that area, or if their ejection fraction is less than 50%. If any of these are present, this individual are at increased risk of sudden cardiac death, and a defibrillator is a reasonable strategy. If none of these are present, then I look for a Holter monitor to see if there's any evidence of what we call non-sustained ventricular tachycardia, meaning rapid heartbeat coming from the bottom part of the heart. And if it's present, Then if it's a child, then definitely an ICD is reasonable. But if it's an adult, then I counsel my patient that a defibrillator may be considered. It is a reasonable strategy, but we have to weigh the benefits and the risk of a defibrillator. And if none of this is present, I look at the MRI. And if the MRI showed extensive scarring, as we mentioned earlier, where this amount of scar is more than 15%, then definitely an ICD may be considered. And if none of these are present, then the patient is at a very low risk and nothing is needed, and defibrillator is not needed. However, we've seen from our European colleagues trying to use calculators to try to estimate the risk of sudden cardiac death. They are available. You can download them on your iOS or Android phone. We plug in the numbers, for example, plug in the age, the width, the thickness, the left atrial size, and the amount of gradient, and that spits a number. And if that risk is more than 6% in 5 years, they're including at increased risk of sudden cardiac death, and if it's less than 3 to 4%, they are at less risk of sudden cardiac death. So what kind of defibrillators we have? We have two kinds, what we call intravascular, where we put that lead inside a blood vessel that goes all the way to the ventricle, the right ventricle. And then there's another kind, what we call a subcutaneous defibrillator, where it sits also under the skin, but over the chest cavity, over the bone, and courses around the bone, and then sits outside the heart. We favor these subcutaneous defibrillators because this means nothing is going inside the heart, less risk of infection, less risk of damaging the valve. And because most of these individuals are younger individuals, we don't want to deal with injury or fracture of the lead. There's less risk of fracture with these leads because they sit outside the chest cavity instead of inside the chest cavity. And what happens if we have a defibrillator? Yes, sometimes this can save somebody from dying. However, this is not going to save somebody from an ICD shock, because some of these patients will get what we call ventricular tachycardia and ventricular fibrillation, and they end up with repeated shocks. And we don't want our patients to have repeated shocks. So sometimes what we do antiarrhythmic medications. These are specialized medicines to decrease the chances of them having ventricular arrhythmia. But sometimes we can't tolerate these antiarrhythmic medications. So we try to rely on something called an ablation. An ablation is destroying the cells inside the heart that promoting these arrhythmias. And often these cells are coming from scar tissue. This individual, for example, what you see is that you see the tip part of the heart in this location is not moving, it's scarred, it's thinned. So, and usually this is the reason for these patients to have ventricular arrhythmias. We go and take this specialized catheter into that area that's scarred, and then we kill that area using what we call radiofrequency or pulse field ablation that kill these cells that are responsible for the ventricular arrhythmia. And by doing that, we can decrease the chances of patients having recurrence and arrhythmia and recurrent ICD shock, so they can have a better quality of life. This is what we usually do. We go inside the heart and we map, meaning see how healthy the inside of the heart. And sometimes we do that from the inside of the heart, and sometimes we do that from the outside of the heart. Our experience at the clinic is that it's not around 20 to 30% of these patients may require cauterizing or killing these cells from the inside as well as the outside of the heart. Yes, that requires a lot of skills, that requires experience, that require being in a big center of excellence that can address these complex arrhythmias. So that's about ventricular arrhythmia and sudden cardiac death. What about the other very common arrhythmia that hypertrophic cardiomyopathy patients have? It's atrial fibrillation. What we see is that atrial fibrillation is quite common in patients who have hypertrophic cardiomyopathy. If we see around every year, 4% of patients will be diagnosed with atrial fibrillation every year. And the prevalence is around 27% if we might put occasional monitors on them, but it's up to 50% or up to 80% if they have pacemakers or defibrillators. Because pacemakers and defibrillator, you have access to the heart all the time. You can get information from the heart. If the heart goes into atrial fibrillation, you can get that information. So what we see is up to 80% of patients who have pacemakers and defibrillator have and hypertrophic cardiomyopathy will end up having atrial fibrillation. Some risk factors that predispose patients to atrial fibrillation is female gender, age, meaning the older the individual, the higher the risk of atrial fibrillation. Also, age at the diagnosis. And this way, if their age at the diagnosis, they occurred at a younger age, the risk of atrial fibrillation is much higher. This tells us because the disease is more aggressive because it got manifested at a very younger age. This means that the risk of atrial fibrillation is higher. Definitely the size of the left atrium, the bigger the left atrium, the higher the risk. The presence of heart failure, the more advanced heart failure, the higher the risk. The presence of hypertension, as well as vascular disease. There's been data, Dr. Tamalarson shared with us some data about beta blocker and calcium channel blocker causing better symptoms, but the way it goes better symptoms, the heart would be able to breathe a little bit better, the pressure inside the heart will be better, and in some studies it has been translated to less arrhythmia, which has been very positive to our patients who have hypertrophic cardiomyopathy. Lifestyle is key. Unfortunately, over the past 20 to 30 years, we've restricted our patients from doing exercise, but that resulted in is patients are obese, patients have diabetes mellitus, patients have metabolic disorder, patients have hypertension. So we're losing that restriction. We're not preventing our patients from doing activity because we don't want to end up with all of these metabolic diseases that will increase the risk of atrial fibrillation in our patients, and we end up hurting them more than helping them. One thing that we have to make sure that patients with hypertrophic cardiomyopathy is they have to restrict alcohol. Alcohol is bad for arrhythmia. Alcohol is bad for obstruction. Alcohol is bad for syncope with these patients because it causes dehydration. So alcohol is really bad for patients with hypertrophic cardiomyopathy. But the risk when it comes to exercise, we ask our patients to exercise, but we like them to exercise in the presence of other individuals just in case. Stroke prevention is key because this is where you're going to save patients. We save patients by preventing ventricular arrhythmia, but also save stroke prevention. When patients have atrial fibrillation, they need to be on oral anticoagulation. The risk of stroke in patients with hypertrophic cardiomyopathy and atrial fibrillation is 8 times compared to other patients with hypertrophic cardiomyopathy and irregular rhythm. This means, and these individuals, their yearly risk of stroke is almost 4%. Every year they can have a stroke, irrespective of their age. And we don't like to use, there are certain scores that would give us an estimation of the risk of stroke in other people like non-hypertrophic cardiomyopathy. We call them the CHAD score or the CHADS VAS score or the CHADS VAS score. All these risks, and unfortunately, they don't matter too much in patients with hypertrophic cardiomyopathy. If somebody has atrial fibrillation and hypertrophic cardiomyopathy, irrespective of their CHADS or CHADS VAS score, they need to be on oral anticoagulation. Yes, there are certain risks, for example, younger age at the diagnosis, the size of the left atrium, the presence of left ventricular outflow tract, the presence of apical aneurysms. All of these things will increase the risk of stroke. And what we know is they need to be on a blood thinner. Aspirin does not work. Plavix does not work. They could be on warfarin, or they could be on the newer drug, what we call DOAC or NOAC, like Plavix, Pradaxa, Xarelto, Edaxaban. Any of these drugs would work well as good as warfarin. How do we treat atrial fibrillation? Because patients often don't tolerate atrial fibrillation because their heart is fast, the atrium is not pumping. We've used sometimes antiarrhythmic medications. We've seen Dr. Tamalarson talk to us about disopyramide. Unfortunately, 30 to 40% of patients can't tolerate that. The other drugs that we've been using, sotalol and dofetilide, we've tested dofetilide at the Cleveland Clinic, and we found that it has reasonable efficacy up to 40%, but unfortunately, around 20% of patients can't tolerate that. We don't like to use the other drug like flecainide or propafenone unless the patients have a defibrillator. And even then, we don't like that. What about AFib ablation? Now this is becoming more like a first-line therapy, especially if you catch atrial fibrillation at early stages where the atrium is not enlarged, where the patient has what we call paroxysmal atrial fibrillation, where the AFib comes and go without the need for a cardioversion. We've had some data from our institution as well as other institutions. What we see is the success rate, the 2-year success rate of doing an ablation is up to 60 to 70% success rate, which is good. Not as good as other individuals who don't have hypertrophic cardiomyopathy, but it's reasonable. But what we see is a lot of these patients may require more than one ablation to be able to manage the AFib. And the reason for that, because it's not uncommon for these patients to have more than one arrhythmia than the AFib. They have atrial flutters, they have atrial tachycardia, and the atrial flutter could be coming from multiple areas inside the heart because their heart is very enlarged. Surgical data has also encouraging data about the success rate of atrial fibrillation ablation. But we don't like to do that unless the patient is going through surgery and myectomy. And this is where we ask our surgeon to address the atrial fibrillation at the same time and clip the left atrial appendage, which may result in lower risk of stroke in these individuals. The last slide I want to talk to you about is sometimes the need for pacemaker after, for example, alcohol ablation and a myectomy. What we see is that the risk of needing a pacemaker after alcohol ablation could be up to 10 to 20%, which is very high. But we don't see that risk with myectomy. And that's thanks to the skills of the operator for the surgeons, where they can cut that myocardium and preserving the conduction system of the heart to keep that conduction system intact, and that would lower the risk of needing a pacemaker. So in summary, patients who've had aborted sudden cardiac death, they need a defibrillator. Patients who have high risk factors for sudden cardiac death, it's reasonable to talk to them about a defibrillator. For patients who get a shocks, they could use medications to prevent the shock or use do a VT ablation, but you have to come to a tertiary center or a quaternary center who are very familiar with this procedure. Atrial fibrillation is fairly common arrhythmias in hypertrophic cardiomyopathy. They need to be anticoagulated, and atrial fibrillation ablation is a reasonable strategy in patients, especially if they caught it early and they have a small atria. And the risk of pacemaker dependency is very low with high skilled surgical operators. And with that, I'd like to conclude and move to the next speaker.
I'm going to ask one follow-up question, and
Yes,
that
yes.
is, in the view of the Cleveland Clinic, with hypertrophic cardiomyopathy patients specifically, what is the role of watchman?
Okay, that's a really good question. So we've been doing actually, luckily, most of the left atrial, most of clots that form in the heart, even in patients of hypertrophic cardiomyopathy, they are still located in the left atrial appendage. So theoretically, we think a watchman for patients who cannot tolerate blood thinner, who have contraindication to blood thinner, is a watchman. You have to consider a watchman. We don't have large sets of data to prove that concept, but what we're reassured is most of the time, and our colleagues from imaging will will also add to this information, and as well as our surgeons, most of the clots in hypertrophic cardiomyopathy are formed in the left atrial appendage. So we think a Watchman or another left atrial appendageal occlusion should suffice and lower the risk of stroke, similar to non-hypertrophic cardiomyopathy patient. However, one thing I want to tell you is that not all stroke come from the left atrial appendage, and some strokes are actually come from the apex of the heart if they have an aneurysm. So if they have an aneurysm or another source that we think that that's the cause of the stroke, unfortunately, we cannot stop blood thinner, and Watchman is not going to do anything for these strokes. But for the strokes that come from the left atrial appendage, I think it should be more than good.
Thank you for that clarification. It's been a hot topic lately, and we're going to be adding some content to the website on that topic. So thanks for chiming in, because your clip may end up being double tasked in another place on the website. Malin, back to you, and then over to Nick.
Well, now, without further ado, Dr. Nick Madeira, who many of you know, he certainly knows many of your chest walls and your hearts. So, Nick, take it away. Please walk us through what's happening in cardiac surgery as it relates to HCM.
I will give one trigger warning for people who don't like, bloody things. There might be some pictures coming up. So Nick, just say, close your eyes when you're about ready to show them. Thank you very much.
Wow, you bet. Well, thanks, Milan. Thanks, Lisa, for all you do. And hello, everyone. There is a disclaimer. I'm going to be showing a video of this conference that I attended, and we videotaped using two different cameras. So there's some very unique perspectives, the far away perspective and a very close-up perspective of what I would see through what we call my loops, my magnifying lenses that I wear during a case. But similar to what Lisa's been trying to do and broaden the educational experience and training across the globe, I was asked at the end of last year to travel to the southwest part of India and put on a symposium to train the surgeons in India to perform septal myectomies. And it was interesting to find out that there are very few surgeons in India performing septal myectomies for hypertrophic cardiomyopathy. And it's, when you look at the population of about 1.5 billion, and if the estimates of the genetic disorder, 1 in 250, 1 in 500 are accurate, that's the upwards of 5 million patients in India with this disorder. And there aren't many surgeons in India that can perform an adequate septal myectomy. So the group at the Amrita Hospital and University, it's a charity hospital in Kochi, India, on the southwest coast, has an annual symposium where they bring a surgeon from around the globe to perform the operation and train the surgeons at the hospital to perform whatever the operation might be. And so I was fortunate to be their visiting professor, visiting surgeon at the end of last year. And we performed 11 operations in 4 days, myectomies, reoperative myectomies, training one of the surgeons, Kiran Gopal, who was a fellow at the Cleveland Clinic. And it's his desire to be a master at performing myectomy. And this is the outside view from the entrance to the hospital. They have a sign not too dissimilar to what signs we put up at the Cleveland Clinic, where they highlight 25 years of doing the impossible. It is a charity hospital. A lot of the patients that come there are quite poor, with very, very limited means. And it was interesting to hear that all the patients and their family members had watched many of my videos and had looked at the videos in detail and knew a great deal about the experience. This is on the other side of the entry, the statue. It's of a physician from about 200 to 500 years before Christ, and he's considered the father of plastic surgery for all the surgery he did for facial deformities back thousands of years ago. And there's a tableau of the surgery that was performed in some of the guidelines he had put together in how to perform the surgery. So it's quite interesting to hear of the really rich and long history of surgery in India. So we had this approach. We reviewed all the cases, just like you saw today. We went over the echo, and I won't bother going in any detail in any one of the cases. We looked at the imaging studies. I would review it with the team, and we would then, together with this, and this is the team in the operating room. These are all the nurse assistants and the techs within the operating room. To the right of me is Dr. Gopal, who trained with us, who's working to master myectomies. And to my left in this photo is the chairman of the department, Dr. Varma, who invited me to attend. And this is the symposium at the end of the week. This is the entire staff of doctors that were and physicians, nurses that participated. There's assistant surgeons are here, anesthesiologists, echocardiographers, imaging folks, perfusionists for the heart-lung machine, the nurses in the operating room. And this is the symposium at the end of the week. And you can see it was phenomenal attendance. It was over a couple hundred physicians that attended to spend 2 full days. And what we did is we reviewed every one of the cases in detail, and then we looked at the videos in detail. And then what I did, which I will do now, is if you were a participant, is show you the video. So if you're squeamish, let me know. But I want to show you, and a lot of people like seeing these videos. A lot of patients, before I operate on them, would like to have videos, and we don't do videos in the operating room per se for individual patients. But this is a look from my perspective of the heart. There's often fat on the heart. You can see the fat covering the heart here. This is the right ventricle. This is the heart muscle, the right ventricle. The left ventricle.
Nick, we're not seeing a video at this
Yeah, the
point.
video is not moving.
We're not moving. We're just watching the guys.
But can you see? Oh, you can't see the video?
No.
Huh.
You might have to, is it a different browser?
Yeah. Do I have to start over again on the sharing?
You might have to, or you just have to drop it in.
So let's see. How
And
about?
I'll say, Juliet, keep your eyes covered. I'll tell you when to come back.
Is it back? Can you see it now?
Now we've got it.
Okay.
Yes, go ahead. Thank
All
you.
right. So this is the heart. The head would be to the left, the toes to the right. This muscle here is the right ventricle, the pumping chamber. You can't see the left ventricle, which is affected by the hypertrophic cardiomyopathy. So we have one camera that's a little far away that is viewing it now. And then we're going to bring a second camera in. You're going to see a split screen. So this incision's in the aorta. So that's the pipe which takes the blood out of the heart, allows the blood to come. I just made an incision in there, and we'll start playing here. And you can see I'm going to open up the aorta so I have access to the heart. There's a little bit of blood in there. The heart's been stopped, so it's rested. So it's not beating. This is a tube that's taking the blood from the heart-lung machine. And so just for the sake of time, I'm going to get to the points by moving this along. And now we put the retractor in there, and we're going to get a smaller retractor coming in on your right-hand side to look at the muscle. Now I'm beginning to cut the muscle. So you can see on the left-hand side, it's a fairly small opening in the aorta that we have to work through. And this is the challenge for surgeons doing a myectomy, there's not a lot of room. And on the right-hand side, you see a more detailed picture of the muscle being resected using a forceps and a knife. And it's very simple in terms of instrumentation. It's a 15 blade, which is this knife here on the left-hand side I'm showing you with my right hand. And in detail, we're cutting the muscle, being very careful to avoid any of the structures below where the muscle's being resected, which is the mitral valve down here, which I'll show you in a little bit. And then we take this piece of muscle out. So I'll move it along here. And so the first piece comes out, and I save the muscle. I put it on this towel so I know exactly where the amount of muscle that I've taken out. So I know exactly how much comes out. Here we go. I can't see the image. So now back on the right-hand side, there's a ledge of muscle that's over here in the septum, and I'm going to try and take that out using, again, the 15 blade. And as Dr. Kanj was talking about, the conduction system, where the wiring system of the heart goes, is right where the scalpel is, just higher up, right where my arrow is pointing. So this is where we have to be very careful when we're cutting, is to avoid coming up very close to this area, because that's where you can damage the conduction system and result in needing a pacemaker. So we're very careful. Now you can see as the camera moves in, the muscle that's been taken out. And these right here, the right side and left side are the two papillary muscles. This is what's called the posterior medial. The other is called the anterolateral. So we're going to move along a little bit. And we're going further and further into the ventricle. We have to keep going towards the apex, and that is what's absolutely critical. Papillary muscle, they're right next to each other. There's no margin. They're millimeters apart. In fact, when I make these cuts, you'll see I score the muscle, and you just have to, because they're so close. But you're carving inside the ventricle in an arch. I go back and forth. So it's this arch to create space so the blood can get out of the heart. This is the aortic valve. We go past the aortic valve and we continue to go deep. This camera showed some really great views of what the muscle looks like. And your heart is a tube of muscle that's wrapped upon itself. So this is all just muscle. There's little blood vessels that will be coming through here. We don't cauterize them. We don't suture them. If they bleed into the chamber, so we don't worry about it. But we're trying to be very deliberate about taking the amount of thickness that we need to take to eliminate the obstruction. So we keep taking very uniform slices on the right-hand side here, so that the septum is reduced by the exact amount that the transesophageal echo suggested we should do. And I'll look inside here and try to find exactly where the thickness ends and stop. But we, on the left-hand side, keep placing the muscle on the table so I know exactly how much has been taken out. So this goes on for about 15 minutes. We're taking more muscle. I'm just scrolling along. And then what we're going to do in a little bit is assess the mitral valve. And I think that's what's really key. As I begin to look, I'm looking at the papillary muscle on the right-hand image. These are white things are called cords or cord A. And what I believe happens right here where my arrow is, I'm going to grab it with the forceps, is this part of the mitral valve, the very central portion of the A2 segment, we call it, gets stretched out from the repetitive SAM. It gets pulled up towards the septum every beat, and it just lengthens. It's a living structure, so it kind of grows. And these cords, you can see these little parachute fine cords also grow, and they flop around. So I'm assessing the length of this anterior leaflet from well inside the ventricle after I've done taking the muscle, and I'm trying to decide whether parts of this, any or part of it, can be removed. And I've determined that I think it's too long. This part right here has grown too long, right there from the tip to, or I'm pointing it out to that spot where I'm holding it. So what I'm going to do is cut this out. It's supported, the valve supported on either side by these cords. There's some over here. There's a whole bunch of them. There's some over here. And I just showed you, that is the line that I'm looking at. That's my dotted line right there. And I'm going to resect that. So I'm going to take a scalpel or scissors and cut this out. So I brought the scalpel in and I take one of these cords that have been stretched out and long. And there's my dotted line right there that I'm going to cut and take this out to get it back to what I think is the normal leaflet length. And so part of what we've done now is, and Dr. Larson pointed it out, with all the imaging studies, and Dr. Zhu pointed out, we study the pre-op imaging studies to get a sense of which component of the heart, the valve, the papillary muscle, the septum, or the combination of those three results in the left ventricular outflow tract obstruction. And now that Dr. Desai is taking all the patients away and putting them on the myosin inhibitors, the patients that I see tend to have thinner septums and often have more mitral valve pathology than muscle thickness, although it can come in any combination. So what we have done now is that real long floppy area of the valve has been trimmed away. There's plenty of valve left, so that doesn't lead to a leaky valve, but it just eliminates the portion of the valve that was flipping up and getting involved with the septum along with the thick muscle. So the papillary muscle, that's what this is, this big, thick muscle. It's like a supporting structure that holds the cords that hold the valve, and the septum are what we assess. And I'm looking at this thickened cord here. I'm trying to see if there's anything I need to do this. So this very methodical assessment of the mitral valve is done in every single case, both with the imaging studies and then on inspection. So I go through every element of it, the left side, the middle, the right side, the papillary muscles and the cords. And then what we would do is assess our results with the transesophageal echo to make sure that what we did has eliminated the obstruction, and the mitral valve is working fine. And that's what happened in this case. We finished up, there was no mitral regurgitation, no obstruction. The septum was fine. And when we finished, what we do is we just close the aorta. I don't know if we showed a picture of that. You can see the inside looks really good. And then we'll just close the incision and be done. And that's the muscle that we took out along with a piece of the mitral valve. So that is a very quick septal myectomy and assessment of the mitral valve. And then I'd be happy to answer any questions about the technique. So was it too gross? Was it too gross, or was it okay?
Not at all. So I'm getting text messages from some people telling me that's the coolest thing I've ever seen. Why didn't I do that with my life? And other people, I'm distracting them, sending them pictures of like fluffy little teddy bears because they can't watch or listen.
So this was good. So I think next we will come to a Q&A session, and I think, Sue and Katie, do you want to turn your camera on? We want to have a little chit chat about we gotta
nurses.
we gotta degrow some people or distract some others. So anyway, Sue and Katie are many of the patients who are on this call, they know them personally, they know them well, they interact with them. They've been with us. I remember distinctly Sue was the day mavacamten was approved. I mean, she had started working with me a few months before that or so. And I think she had a look on her face. What the heck have we gotten ourselves into here? So she's been there from day one. And Katie joined a few months later as we quickly figured out we need to operationalize this. More importantly, lead the path forward, because everybody was looking at us how to execute this, and they have been extremely good. So I want your opinion about the REMS logistics, how you helped get us. And now it is basically, we don't even bat an eyelid. I mean, it's par for the course. It just happens as a routine. And I must say, Lisa, more than a third of our patients are on, I mean, they don't come to Cleveland Clinic. They get their echoes done locally. Everything is transmitted electronically. Sue
So
does a lot of virtual
before
visits, all that.
before we open Pandora's box and ask Sue, how's that REMS program going? I think it's kind of important to announce, if people don't know this already, in April, the FDA is going to hear, or BMS is going to hear back from the FDA on whether or not there's been an amendment to the REMS.
Mhm.
And I think they are expecting some change, which would probably make it less laborious for clinician and patient. I haven't seen the recommended language yet, so maybe we can comment a little bit on what that might look like. But Sue, what would that mean if we're making your life a little bit easier?
Find something else for Sue to do, I guess.
I'm
Yeah.
sure we have no problem with that.
Well, if we end up with non-obstructive patients eventually, I'll have plenty to do.
Oh, go ahead, Sue. Tell us, Sue and Katie, I mean, from the moment, so first, Katie, so I text you or call you, say, patient in room 2, maybe a candidate. From there on, walk towards it, and then Sue, take on in terms of the follow-up piece.
Sure. So I start with some patient education, going through everything that you've already discussed with them in terms of a little bit about the disease, but then really getting into Camzyos and the logistics of the REMS program. So making sure that they are aware of a couple key points, the drug interactions that we all know about, the signs and symptoms of heart failure that we want them to keep an eye out for, and then the echo requirements. And so really making sure that they understand what it's going to look like on their end in terms of getting these echoes done within a specific 6-day time window. If they do choose to have the echoes done elsewhere, making sure that we work with their facility or their local cardiologist so that we're getting a good echo, we're getting an echo in a timely manner, kind of addressing those things up front. And then from there, we go into the prior authorization, making sure that we provide all the information that their insurance company would need. So things like their symptoms, their NYHA class, other medications that they have already tried, any of their echo measurements, wall thickness, ejection fraction gradients. Oftentimes we do get a denial, so then we're working through the appeal process on the patient's behalf until we ultimately get the medication approved and get things started. Usually I like to have the patient call me before they take their first dose so that we can set up the first 3 echoes before they even start. That way we know everything is set, we're organized, and hopefully things go smoothly. For the patients that are coming to our center for the echoes, we work directly with the Echo Lab supervisor to make sure that we can get those scheduled when we need to. And then, as we've mentioned, a lot of our patients do get their echoes done locally. So we'll send the echo orders to their facility. it's up to the patient then to make sure that they get it scheduled within that time frame. We do give the windows to the with the order, but the patient does need to make sure that they're part of that scheduling process. And then we need to get the images and the report from the outside facility so that we could then do a virtual visit, oftentimes with Sue or one of our other providers, before we can fill out the REMS form in order to get their next month of medication. So there's kind of a tight timeline that we're working with. And so I think that's why it's important that the patient knows upfront what the expectations are, and that there's good lines of communication throughout.
So patient is now on it and come back. So what is your logistics, Sue, and how do you handle, the virtuals and the inpatient, I mean, the outpatients, et cetera? Let's talk about the virtuals. That's a unique part of our practice because a lot of them are from out of state.
Correct. So actually, sometimes they're virtual videos, sometimes they're virtual telephone, because everybody has different comfort levels with technology. So that is something that, makes sometimes a little more difficult. It's nice to be able to see the patients so you can see that they're doing okay, but occasionally it's not possible. And so, in terms of scheduling, we schedule whenever I can get it scheduled because we are working on such a tight, we only have a certain period of time. Patients get very nervous when they get down to 1 or 2 pills. And luckily, we have been able to work out with the pharmacy through the REMS program. They are able to usually get a small extension on the medication in terms of a small number of extra pills, which is helpful because a lot of these patients, things come up, they end up in the hospital, they end up, or there's a snowstorm and they can't get to their echocardiogram. That's happened recently a couple times. So, part of what I do, I think, is try to keep the patient calm and make sure they understand that, if they happen to miss a dose of medication, it is okay because it has a long half-life, etc. We don't condone, missing medications, but if it happens because some of these patients are like literally calling the pharmacy every single day to try to get their refills. And so I can imagine it's very anxiety inducing. So we do the best we can to make sure that we're able to, I guess, make it as easy on the patient as possible.
So one thing, and now compared to say 5 years ago, pre-COVID or pre-Valor or what have you, our practice has gotten very complicated. We are no longer just talking about beta blocker followed by myectomy. It is this trial, this gene therapy, that follow-up, this follow. So you've been very, very helpful in terms of a lot of. Sue also has a role in research. So you spend some time as my research NP. And a lot of our Odyssey Valor patients are from, in fact, majority of or a lot of patients are from out of Ohio. There are people flying in from Seattle, from California, from Arkansas, etc. So tell me how you handle those and how you help me handle those and your experiences related to that.
So the research is actually working with the Odyssey patients, especially after learning what we've learned about mavacamten with the obstructive patients. It's been very interesting, and a lot of patients are very excited. There's a lot of non-obstructive patients who are really banking on this, the Odyssey trial and the results from it. I have to say it is difficult because I'm constantly switching gears. It's research patient, Camzyos patient, research patient, and then it's regular clinic patient. So sometimes it's really difficult to keep it all straight. And but we're managing the best we can. So
We
We are always
appreciate it.
Yeah. AI, Katie, you helped us, just last question. You helped us set up very helpful in our AI ECG pathway. So how are we handling the deluge?
So we are working with an FDA approved algorithm that analyzes ECGs that are done at the Cleveland Clinic. And then we get a list of those patients who are suspected of having HCM. And once we get that list, myself and some others will take a look at that list and try to kind of whittle it down and find out, are these patients, is there maybe something else that is causing this flag that it may not actually be HCM? Is there something that makes us think this truly could be HCM? And if so, we are reaching out to the patient's physician, letting them know about this algorithm, and then recommending that they may want to do some additional follow-up in terms of imaging and testing, so that we can identify more patients and then get them the treatment that is needed.
Lisa, you want to open up for Q&A to
I
all of
do
us?
want to open up for Q&A, and I want to say that I have a timely Facebook post, which was literally 10 minutes ago as you guys were talking. My little ding goes off, and it's somebody who was denied a Camzyos prescription, and they're starting the appeals fight. So unfortunately, whether it's Camzyos or another new drug to market, we're going to continue to have these problems with access. And it's going to be really important for us to speak as a collective voice to allow physicians to be physicians and prescribe the therapy that they believe is best for their patient, and put insurance companies back in their space where they belong, and have them stop practicing medicine without a license, because they're really starting to get me annoyed. But I will step down off of my soapbox from that one for now. We do have a bunch of questions, and let's kind of go rapid fire, seeing as we are running a little bit late. Oh, now you're all getting very chatty in the chat box. Okay. So I'm going to stick with, we're going to try to do this in order. Now I can't because they're all out of order. All right, we'll start with this one. What's the typical time frame for being able to get surgery after it's determined that you are a candidate? What's the lead time for myectomy at the Cleveland Clinic these days, Nick?
About a month, maybe a little less.
Month, maybe a little less is about right. Unless, look, if we perceive an urgency, then it could be a direct phone call or walking up to the fourth floor and a direct chit chat, and sooner. Maren, what do you think, Bo?
Yeah, I agree. I think definitely. I mean, it can get people in very quickly, and people that need to go quickly will go quickly. So,
Yeah, I would agree with that too. Generally, the patients get expedited treatment.
That has been my experience as well. And if somebody's kind of in a hurry, that happens. But I would find that most people need a month to get their head around the fact that Nick's going to be touching their heart. And that's okay to take the time to get yourself ready. We also offer a pre-myectomy discussion group to prepare you for surgery if that's the path that you're going to go down. So sometimes I take your questions and I reformat them to give the same answer. So the question is about gradient, and do you make your decision on therapy solely based on gradients? I will say in the 100 to 150 range. If a gradient is 100 to 150, are you going to make a decision, Cleveland Clinic team, on drug therapy or surgical therapy based on a number?
Not really. Not really. I mean, we never send So look, we publish data on stress echocardiography. If a patient comes to us, especially with a high gradient, whatever, and say they're asymptomatic, that's a starting point for negotiation. I'm going to say, prove it to me. Let's walk on a treadmill stress. I mean, that's the genesis of some of our early stress echo papers that we wrote is, 426 patients who came into Cleveland Clinic saying they were asymptomatic. We put them on a treadmill. Less than 50% of them achieved their age gender matched exercise capacity, and we sent them for surgery and they did much better in the longer term. This was before the mavacamten story. And in fact, more than 2,000 myectomy patients, we took people who we sent based on current guidelines and some patients who we sent earlier based on impaired functional capacity. And those patients, the ones who we sent earlier operation, did much better in the long term. So now the rest of the crowd, the rest of the world is catching on and talking about an earlier myectomy. But we've always espoused the fact that we need to put them on treatment early. AFib, same thing, much earlier. Me sending people for an AFib ablation is much earlier now than it has ever been. Marn, Bo, Mo.
Yeah, no, I agree. I think definitely, and also the cardiology, we are going earlier. I mean, I think aortic stenosis, valve disease, mitral leak, recognizing that it does take a toll on the heart. And so instead of, say, waiting a long time, earlier is better. We like a more sustained result and probably overall improvement in heart function in the long run as well too. So I think if we, so we don't look at a number automatically, when you see a high number, we have to prove that it's not causing limitations. And if it is, then it's best in the long run to address that. I think we all agree with that. So
I think we've all finally come to the understanding that when a patient says, I'm fine, it typically means I've learned to cope with diminished quality of life. And that we need to really define what is good, what is fine. And sometimes we have to admit, and I can speak up as a patient who didn't realize how sick I was until I was that sick, that I needed a new heart. And I'm like, oh no, I'm fine.
Another thing, Lisa, the things we've learned, we did not appreciate it as much in the purely myectomy days that we are appreciating right now. And I think Sue has become probably the queen of this, is, in the era of mavacamten, et cetera, now that we obliterate the gradient, we are starting to quickly down titrate the beta blockers and it's hard to, and patients feel so much better. Is it because the gradient is gone, or is it because their DISO is gone, or their beta blocker is down from 200 milligrams? A lot of these. And now for the first time, we are able to treat high blood pressure appropriately, according to guidelines. Sue, your thoughts. I want to hear your thoughts about the beta blocker. She's the queen of, can I cut down the beta blocker?
Yeah. Oh, Lisa, did you have something you wanted
No,
to say?
I was just going to pivot for him. Go ahead, Susan.
Okay. So yes, the beta blocker is a big issue, especially with the younger patients. Younger men especially don't like beta blockers. So there are some we've gotten them off completely, some still need them to some degree, but we've definitely been able to lighten the load in terms of dosage. So that's been helpful. Also, to speak to the blood pressure issue, um, it's very helpful to be able to use medications that are more geared to blood pressure than metoprolol. And so we often get better results with, managing their blood pressures on ARBs. And we don't use ACEs as much, but we do use a lot of ARBs. And before that was kind of taboo. So it is definitely helpful. And then I was going to say something and now I can't remember what it was. So we can move on now.
We've got some rapid fire questions coming up. Nick, going back to India, how long was the recovery for the patient in the surgery video?
In terms of in the hospital there? Is that what
Give us whatever you want.
Yeah, so their approach is a couple days in the intensive care unit, and then a couple days, maybe 4 days on the regular floor. They don't discharge as quickly as we do in the United States, but pretty much their care is very similar to ours.
So in the United States, what is your average hospital stay now for myectomy?
It's 3 to 5 days.
That's crazy. It used to be like 7 to 10. Like they just hung out and like chilled with you.
You
Now
know,
it's 4 days,
it's
you're done.
you're done. And anesthesia, the anesthetic's much better. I think the heart lung machine is more refined. You know, we try to make the surgery as quick as possible. So we have patients operated on Friday that go home on Monday.
That's crazy. Okay. So nurse practitioner to PA, got a question from a PA here. How many patients do you have on MAVA? Does each echo visit get a clinical team exam for MAVA? And are you adding SGLT2s? There you go, Annie.
So Katie can give us a better idea of exactly how many patients. I primarily work with Dr. Desai's patients. So in terms of like the full spectrum of our HCM patients, I can't really comment on that. Um, so each mavacamten visit, basically, you know, it's if they come into clinic, full physical exam, vitals, they have their echo, we discuss, and then, you know, Katie helps me do the REMS, or she does most of them actually. I help her out, I should say, when she needs it. The telephone and virtual visits, obviously I can't do a physical exam, but we still go through the same questions. We go through, you know, there is some management of other things like, well, how's your blood pressure been, especially if they're on the beta blockers and we might need to transition them to something else. So certainly time intensity, virtual and telephone visits are much shorter, but we go through the same general. Especially with the first couple visits where we're doing that every 4 weeks, it's very heavy on education, because some of the education they got as they were being told of this diagnosis, and or they're being told of this while we're talking about a new medication. And I think sometimes people zone out and they get so caught up in their head that they really aren't fully digesting all the information they're getting. So I try to reinforce as much as possible, to make sure that they really understand what's happening in terms of their heart, and you know what the mavacamten is doing for the heart. So
Katie, can you give us an idea of some numbers? And then I'm going to pop over with an ICD question. So get ready, Mo.
Yeah, so within the imaging department, which is essentially this group here, we have about 250 patients on Camzyos. And then obviously, if you include a few other departments, regional hospitals, Florida, there's, you know, quite a bit more when you include all of those locations as well.
More than 300. You're going to wait for the presentations, Lisa, at the upcoming conferences for more details.
I will hear
What
it
you
all
are.
at ACC and I will pass it along to the community. So we have a question from Lonnie. Hi, Lonnie. He had his first ICD put in December of 23 below his collarbone. So I'm guessing we have a, you know, transvenous device. About 6 months in, it started to sag and it dropped by about 1.5 inches. Is this a normal thing that happens after an ICD is implanted? Should he be worried about this, or is this normal?
This is not uncommon. There's a lot of factors where the physician put it in, whether he or she put a suture to the muscle, the weight of the actual device, whether the patient is taking steroids. That weight actually could bring the device down. I think one thing we have to be careful, if that device went down too much and it's sitting on top of the heart, then retesting the defibrillator is needed, because you want to make sure that this device works for you, because it's so on top of the heart, most of the energy is going to go forward and you're not going to be shocking the back wall of the heart. So I think I would follow up with my local electrophysiologist who put it in, and if it's not bad or doesn't keeps going down, which I doubt it, you may need DFT testing.
Having had a device shift in my chest. I fell, it moved 3 inches, it tore the skin open. You want to get them checked if it's migrating a lot, but don't do some of the things that I've done, people. It's just not very fun. Okay, so we've talked a bit about this. So I'm going to merge a couple of questions together here. So Marcia, I'm going to merge yours and our anonymous attendee. So we're asking some questions about myectomy versus myosin inhibitor. Now there's going to be a potential another myosin inhibitor to market come September with aficamten's PDUFA date coming in September, I think 25th or 26th. And then we're going to get an updated REMS, so an updated label potentially on Camzyos. So there's going to be some changes coming, but more myosin inhibitors. Is there a difference between life expectancy that we can talk to people about now between myectomy and myosin inhibitor? What do we know?
So the short answer is no. They have not been tested head to head. First and foremost, CMI is still very brand new in terms of lifespan. It is 5-6 years ago, it did not exist. So, the short answer is no. Having said that, myectomy, we have large series published in more than 2,000 patients. We are actually looking at a even larger series of overall HCM experience at Cleveland Clinic. A well-done surgical myectomy, we have shown this data, Mayo has shown it, a few other centers. Well-done surgical myectomy will bring your life expectancy to similar to an age, gender matched normal population. So absolutely, because remember the other things, and I want Nick to chime in also about it, is you also identify coronary artery disease and some other things that you fix. So no wonder people will, some of these unintended badness you identify. Nick, that plus I wanted you to address where do you see 5 years from now? All these, the folk, our friends in China are doing these beating heart myectomies and these ablations and this and that. Where do you see the future?
Oh, I don't know what the future holds. Like you said, there's so much exciting work going on in hypertrophic cardiomyopathy with the drugs, the gene therapy, different forms of less invasive, the radio frequency, this beating heart approach that the Wuhan group is developed, which I think is quite effective. It avoids the heart-lung machine, very rapid recovery. So I think we're going to have the patient, to your earlier comments about shared decision making, will come to a center like the clinic and have the opportunity to explore all these different options. And we won't have all the answers because some of the data will be early. We won't know the long-term outcomes of being on a drug for many years or the ablation, so on and so forth. But there's a lot of opportunity and a lot of exciting thing going on in the field. But a center of excellence is necessary to outline what's best for the patient.
One comment, this sort of, I got into a discussion on just last week when a cardiac surgeon made a comment that he's never had to have done anything more than a myectomy to relieve LVOT obstruction. Only people who get in trouble. That was the implication. They resort to mitral valve repair, etc. My argument there was, it's a referral bias. We see the more complex anatomy, thinner septa, all that stuff. I want your thoughts because you clearly have done more than 5 times the amount of myectomies that professor had done. So,
yeah, there's rarely anything in medicine that's always or nothing. So that's an unusual comment. Thick 20 millimeter or greater septums, all you need is a myectomy. As they get thinner and thinner, or they have really complex mitral pathology, I think you need to do something on the mitral. The other point I would make for surgeons and centers that are just beginning to do myectomies, if you do what I call an adjunctive intervention on the mitral valve, as you're learning to safely take more and more septum muscle, I think that's good for the safety and well-being of the patient because a ventricular septal defect can often be lethal. So to be bold and brave and take a ton of muscle and have a problem is really hard to fix. So I don't know, I mean, people have different perspectives, but my approach is do the safest thing that eliminates left ventricular outflow tract obstruction without replacing the mitral valve. And you've done the patient a very good operation. So no absolutes.
We have a follow-up question on myectomy, and we have somebody with their hand raised. Please take your hand down and put your question in the question and answer box. We will try to get to everything, but we are running really late, so we're going to try to wrap up so everybody can get some sleep tonight, because some people might have to do surgery in the morning. Somebody's question, and I'm going to read it as it appears, because I think there's a misconception just in the wording of the question. Why does the septum grow back in myectomy for some patients? Thanks for the demo. And thanks for all you do. Are septums growing back, or are my myectomies sometimes incomplete? And potentially, does the geometry of the ventricle change when you move some muscle away?
It's my impression, and my colleagues can tell me if I have this correctly, is that you don't grow more muscle as an adult. My experience has been in patients that need a second myectomy, it's because not enough muscle's been taken. If some muscle's been taken and there's continued obstruction, you'll get a layer of fibrosis that's laid down on the muscle, and it appears that the thickness has returned, but it's really a layer of fibrosis that's returned to kind of return the thickness. But if an extensive myectomy is done, I have not seen a recurrence of the muscle thickness. I've just not seen it.
Maren and Bo, so all of us do advanced imaging. The other thing, Nick, we published about this, I think, way ahead of its time, like more than a decade ago now, is the heart changes shape, the angle at which the aorta comes out. Bo and when we read MRIs, we see this all the time. Do you think something like that happens with aging that may add fuel to the fire in addition to a suboptimal myectomy to cause obstruction?
I think so, especially in our older population, female patients, whereby the heart cavity size tends to be smaller, and in a lot of patients with changes, you develop what's called a basal septal bulge, and with the unfolding of the aorta, that can create septal hypertrophy and potential obstruction down the track as well. But I do agree with Dr. Smidira, and some of my patients having had redo myectomy here, prior surgery was done elsewhere. I think the biggest issue is really the initial operation being insufficient.
Yeah, or I think that also might have been a mitral valve issue on top of it, that maybe there was a good myectomy, but they didn't recognize the papillary muscle or the mitral valve might have been an issue there. And as far as the angulation, Dr. Lever showed that years ago with Bernadine Healy, showing that as we get older, the angle between the aorta and the left atrial flash gets more narrow. So any given septal bulge can cause more obstruction. So that's been going back to early days of HCM research there. So.
Just went through some history there. Okay, so we got a lot of questions, and I want to try to get to as many as possible. So I'm going to jump on. Bill, thank you for the offer for the introduction to the state representative. I'm going to ask you to contact Julie Russo, our legislative lead. Julie will be looking forward to having a conversation with you and seeing what we can do to get things moving there. Thank you for that. So that's great. We got a lot of Sioux fans out here tonight, a lot of shout outs and a lot of you rock and all that kind of fun stuff. So didn't want to not give those messages. Melissa, you had surgery in August of 22, but found out that you weren't an HCM, that you were another big heart. You had amyloidosis, which was identified during your myectomy. So not incredibly uncommon, but not common. And we here at the office would actually like to talk to you about that experience, because HCMA is building out some more educational content on the crossover between HCM and amyloid. And we'd like to share a story like yours. So if you're interested in helping out in raising awareness, we would love to speak to you about that experience. And I'm glad you got to the right answer as to why your heart was thick. Somebody who has non-obstructive HCM for 40 years and beginning to see more heart failure. What are the options for somebody with a burnt out or low ejection fraction heart in HCM?
Flat.
So who wants to talk about the T word?
So I can handle that. So yeah, I mean, once you get into the about 3 to 5% patients in our experience develop advanced heart failure, or what we call burnt out hypertrophic cardiomyopathy. Majority of them will develop reduction in LV ejection fraction, so they are not really candidates for mavacamten or cardiac myosin inhibitors. And once they reach a certain threshold of poor impaired exercise capacity, we measure it on that cardiopulmonary exercise testing, then we are talking about listing for transplantation. Now, as I said, it's a very small proportion of patients. There's another group of patients, as we've seen and experienced. I mean, we share a few patients like that, is they may not develop LV dysfunction, but it's just a thick, very thick, small cavity with apical aneurysm or overall thickening. So we've done what we call debulking myectomy, where we just shave the living daylights out of the muscle to increase the cavity size. And Nick and I mean, we are a little bit more stringent in who we send for these myectomies. I think, we do put them through a lot stricter ringer. And our outcomes have been pretty darn good. So mostly transplant, small proportion of preserved EF kind patients with thick heart, we do a debulking myectomy.
Okay, I'm going to do rapid question answer. And this is where everybody shakes their head or says no. And if you say no, then I'm going to turn the mic to you because that means we've disagreed on something. Can mavacamten reduce the size of the dilated right atrium or dilated left atrium? I thought it was a trick question. So it can show regression in left atrial size. So we're all like, yes, it can happen. It's not a guarantee. It won't happen for everybody. It might happen for you. This is still from the flu a month ago. Sorry about that. Okay, so yes, that can happen. Can somebody take 225 milligrams of Toprol to equal a 50 milligram pill if they don't have a 50 milligram pill? 50 milligrams is 50 milligrams. It doesn't happen. Don't worry. Just take the ones that you've got. Cancel. Okay, so we answered that one live. Done. What does it mean if somebody's the puppy? Nick's got a puppy. It's getting late, people. The dogs are coming in. The dogs have been let into the meeting.
And it's time to go to bed.
It's time to go to bed. So we're going to wrap quickly here. Okay. So I'm going to do this one. Do beta blockers and calcium channel blockers help gradient much?
There's a moderate benefit. Like that's good, it's modest benefit, and some people it's enough to get them feeling better, so.
Exactly. So we used it for many years for good reason. It's not that it doesn't work, but sometimes the side effects can make somebody not want to continue down that path. So we have options now. I'd encourage you to take a look at all of your options. Can aficamten and mavacamten be a problem for people with dilated hearts? Yes. They're contraindicated at this point for anybody with an ejection fraction under 50%, either in the clinical trials or in commercial use. Everybody agree with that one?
Yes.
So this person, the amyloid person again, call me amyloid person. Fran, there's no form like this in Australia, but I want to tell you, we're working with our partners at the Cardiomyopathy Association of Australia and New Zealand to help them develop so that they can bring you programs like this. But HCM management is pretty much worldwide these days. There are some drugs and procedures that may not be readily available in Australia yet, but we're working with them to increase care. So stick with us and reach out to Lee Bell, who is leading up the cause down there. She needs some help too. So not only can you get some services, but maybe you can give back a little bit. Nick, do you ever operate on just a mitral valve, or with it when it's HCM, do you always play with the septum?
No, I just did a case where they had outflow tract obstruction without a lot of hypertrophy, and we just focused on the mitral valve.
Debbie shouting out, Dr. Larison. Hope to see you when I'm there. So say hi to Debbie.
Debbie.
Is there any significance when there's an insertion of the papillary muscle to be apically displaced on MRI? So let's go down to Bo. We haven't heard from him in a while.
Yeah, well, that's often something we'd like to comment on the MRI and advanced imaging, apical displacement, or whether they're multi-headed with arborization. It's another sign that the pec muscles may be abnormal. A pec muscle abnormality is certainly the important contributor to LVT obstruction in some patients.
Thank you so much. Is mavacamten forever or for a short period of time?
I mean, the way the drug is designed, yeah, you have to take it, and if once you let it wash off, the gradient tends to come back. Now, what we don't know is what we are seeing in trials is long-term taking. It reduces the muscle wall thickness, the left upper chamber thickness. I mean, the size, etc. So, could there be a time down the road after you've been exposed to cardiac myosin inhibitors for a while that it changes the milieu to a point where the obstruction no longer occurs? We don't know. We don't know that. Only time will tell. But as of right now, you got to take it for the symptoms to be at bay.
Okay, we're going to pivot over to Mo. And this is, should everybody with HCM who has apical HCM be on a blood thinner regardless of CHA2DS2-VASc score?
If they have AFib, yes. The incremental increase in risk of stroke with CHA2DS2-VASc score does exist, but it's not a big thing. So AFib, hypertrophic cardiomyopathy, they need to be on irrespective of CHA2DS2-VASc score.
And an apical aneurysm, you would do the same?
Yes, if they have
Okay.
AFib.
Yeah,
Okay.
if they don't have AFib, I think it's still.
Yeah, if they don't have AFib, yeah, you're right.
But
I would leave you to answer that question.
That's right. The bigger the
Trick
aneurysm
question.
is, and maybe the bigger aneurysm, we think there's more substrate for blood stasis. So look at a small little nubbin. We a case by case basis to review that. I think what to do without AFib and a small aneurysm, I think is still something we have to kind of arrive at what is the best treatment option.
Perfect. What happens with these people who run really low blood pressures with HCM, 85/60 is their normal blood pressure? What should they be doing to manage the symptoms of low blood pressure?
That tends to be tricky, right? Martin, go ahead. You were saying something.
No, I mean, if it's significant obstruction resulting in the blood pressure, then we need to kind of target that obstruction. If it's not obstructive and they're low blood pressure, the question is there some autonomic problem on top of that we need to focus in, because there can be some issues there as well too. But if it's obstruction related hypotension, then we need to address that.
We have actually, I just remembered, not less than a month ago, one of Mo's partners, who is a syncope specialist, he had a patient who was sent to him for syncope evaluation, for dizziness evaluation, like tilt table and everything. And the patient had a great, undiagnosed latent gradient of more than 80 millimeters. So clearly we had to address that. And the patient is now pretty much cured now that we are treating the obstruction.
We have an anonymous question of how much alcohol should be limited with HCM. Now, I know Harry Levers probably is listening here and he's saying no alcohol at all, but can patients with HCM have a little bit of alcohol, and what's too much?
So I don't drink alcohol. This is my standard line to my patients, and folks may disagree, but I say 0 is better than 1 and 1 is better than everything else. That's how I say it. What do you guys say? Bo, Maren?
I agree. Yeah.
Yeah, I generally advise against alcohol. Like Dr. Kanch mentioned, alcohol is really bad for AFib and exacerbation in HCM. Having said that, if they had HCM treated with myectomy, they're doing great, and they're celebrating birthday, 1 drink should probably be okay.
Okay, so the only person here who's had HCM and alcohol, I'm going to give the following real life advice. For every drink you have of alcohol, have a drink of water before and after it to keep your hydration balanced, it's a much more pleasant experience. And don't overdo it. No binge drinking. A drink and water, a drink and water, and you don't get a headache afterwards, and you don't get hungover either. So don't overdo, but keep your hydration up.
So the data on AFib is no more than 3 drinks in a week. And it's just not just a dehydration. It's actually promotes fibrosis in the atria and increase the level of inflammation that causes AFib. So I don't think we want patients to hide. It's like, hey, I'm going to promise I'm going to be hydrated and I'm not going to have any bad effect. So because it does increase inflammation and fibrosis.
Alcohol is probably not really good for you, but if you want to have a drink,
Yeah, I agree.
do it safely. Do
yeah.
it safely. Don't binge. Don't drink a lot. It's probably got a lot more bad to add to you than good. So just think of it that way. So Tiffany's asking a really good question, and then we're going to do 3 more, and then we're going to be done. If beta blockers and calcium channel blockers don't have a big effect on gradient, then why don't we take them away if you're going to add in a myosin inhibitor? And I think we need to talk about underlying heart rate and heart rhythm as it affects to gradient. And I'm going to say something that you're all going to laugh at. Melinda, you have 1 minute to answer this.
Okay. So I'll be less than 1 minute. So yes, I mean, and that's what we are doing essentially in our practice now with mavacamten. You know, if it shows an impact, we are quickly cutting down on these ancillary things. Now, sometimes you may need rate control if you are going in and out of atrial fibrillation. So we have to balance that also. And obviously there's an ongoing study called MAPLE-HCM that is looking at potential role of cardiac myosin inhibitor as a first-line therapy instead of beta blocker. If that is positive, that's going to make our lives even more complicated from a prior authorization perspective. So, you know, it's a nuanced approach to taking care of these patients. See, I was under 1 minute.
Close. It was close. Okay, I'm going to group some questions here. The webinar will be available. We did get onto Facebook. I forgot to tell y'all we're on Facebook too, but probably halfway through the second or third talk, we got it to go live. So you can pick it up on Facebook. The entire webinar will be available on our YouTube channel and our website shortly. Sorry. So we've got 2 questions on AI. So number 1, HCMA is also working with BizAI on some other initiatives that we might be utilizing AI in other ways. This technology is not proven or FDA approved for children under 18. So it can't be used for community screenings at this time, but we are interested in a research project to evaluate that potential utility. And I believe that everybody at the Cleveland Clinic, your EKGs are all going through Viz at this point. And no, you can't just send them your EKG and have them put it into the cloud. It has to be done. It's not done on the paper. It's done on the electrical currents that make the paper line squiggly. So some of our centers of excellence are using this technology right now. Others are coming on board later. But it's an interesting technology. It's not 100% accurate right now, but it does give us some guidance and suspicion. And I'm hoping that maybe in our All Hearts Collaborative, we might be able to use this technology as well. So that is that. So the last question of the night is going to be the complicated one about kids. How young should you test children? My mother is diagnosed, and we do have genetic testing into the family. So if you have knowledge of your children's genetic status, when should you begin screening? Typically, we're advising people here that when you get the genetic results back, you want to do a baseline EKG and echo, and then at least EKGs annually, depending upon the age, and echo and EKG as they are approaching puberty, which can start as early as age 8 in girls today. So that's what we're looking at this point in time. The guidelines are a little still hazy on here about how often to screen, but definitely not every 5 years, which I was still being told by some people. Every 12 to 18 months from age 12 through full growth is typically what we're looking at. Anybody have any other information they'd like to share on families?
I think generally consistent with what we recommend anyway. I mean, look, two things I'll say about the children is make sure you see a competent pediatric cardiologist who's comfortable and confident, and make sure when you transition from childhood to adulthood, you're not lost in the shuffle where, for a decade you are not seen and all of a sudden now you present with advanced symptoms and wish you were there early on.
Okay, I lied. There's one more question and it ties into a trial we're recruiting for right now. So HCMA is working with Lexicon on a recruitment project. Many of you would have joined us a month ago tomorrow for a webinar on that trial, which is an SGLT1, SGLT2 combination drug on top of everything else for therapy. So congratulations to our amazingly engaged community. We were charged with recruiting 125 individuals who were interested in learning more about the trial. We are closing in on 200, so the trial is now closed. And in under 30 days, the HCMA recruited the entire population that was needed for this trial. That is astounding. Congratulations to everybody. Those referrals are all going out this week. So thank you internally to the team who helped it happen and externally to all of you who showed up. So we don't know about their role, SGLT2s in HCM. There really hasn't been any real good studies yet, but we're hoping to gather some more data. And I know a lot of you are already on Farxiga and Jardians, and it just seems to be working well, but we still need to do the studies. Does anybody want to comment on SGLT1s or 2s in HCM?
No, I think there's showing data on heart failure, preserved EF in general. So I think if we extrapolate, physiology is very similar. Now, they do have a little diuretic effect of those who are obstructive. We want to be careful because that can exacerbate obstruction. But I think certainly it's exciting. I think we're learning more and more about them. So I definitely think this trial is needed, and glad that we're able to hopefully get some data soon.
Fantastic. I am going to let the last two words be the last two comments, one on Facebook, one in the chat room. Nick, you're getting some love out here. Just need to make sure it gets back to you. So Karen, whose husband had a myectomy in 2004, saying thank you. He's doing good. She's out on Facebook. And then we have our amyloid HCM friend saying thank you because she got to see 2 more grandchildren because she was able to improve her quality of life through your help. So there's so many of them out there, Nick. So as much as myosin inhibitors are so cool, you and I have been dancing this dance for 25 years, getting these people the care that they need. And a lot of them have really long-standing benefits. So bravo to the entire team that's allowed that to happen with such consistency over the years. And full disclosure, we let Nick operate on my dad, and I love my dad. So tells you a little bit about what we think. So Nick, thanks.
No, you're so welcome. And to the patients, it's our pleasure to take care of you.
Okay, well, we have finished all the questions. We went long. Thank you all for sticking with us. We cut down our population by half, but there are 51 of them still hanging out there listening to those Q&As because they want to know everything you have to say. We thank you for sharing your knowledge and your talents with us all. We appreciate the partnership that we've had with Cleveland Clinic since the very, very beginning. So I'm not sure if Harry's still awake watching, but he should be awfully proud of the legacy that he has built and left behind, because you guys are all doing fantastic work and we love working with all of you. So thank you. And thanks everybody who watched.
Thank you.
Thank you.
Thank you.
Take care.
Thank
Bye-bye,
you for
guys.
joining. Thank you for the invitation. Thanks. Good. That went well.
Yeah, and we're still stopping. So we're live on Facebook and we are ending the room, and all the people are filtering out. So thank you, thank you, thank you.
Thank you.
Thank you.
Appreciate it. Thank
Good
you.
night.
Good night.
Thank you. Good night. Bye.
Night.